A big hello to all those that are streaming either live or later this afternoon at a more convenient time for them. Big day today. We've got two great presentations, and then we've got some tours that are happening from the Trans Resort, as well as a number of other little day trips that people are taking. Please take photos and use the hashtag EMS Conferences. We only have a couple of entries at the moment, so if you do have any photos from the last couple of days, send them through over the next hour or so, and we might be able to get them in to get you a prize today. Otherwise, Thursday and Friday will be prize bonanzas. Some of the prizes is Rebel Sport vouchers, Dan Murphy vouchers, and we also have an iPad to give away on Friday. So, that got a few people away, doesn't it? Yeah. So, same setup as yesterday. So we're going to do our first presentation. We'll have a little break, then the next presentation. Still plenty of food, teas and coffees outside, so please feel free to grab anything at any stage that you need. And then Scott and Alex will be returning as well for an optional session if anyone wants to hang around and have a chat to them. But that's enough from me. I'd now like to call up Hayley and Viv. Hayley and Viv presented for us in Queenstown earlier this year on Victorian Virtual ED, and it was really well received, so we're stoked to have them back. So please, let's make them feel really welcome with a big round of applause. Hayley and Viv.
Okay, good morning everyone, thank you for coming. My name's Viv, I'm one of 9 Associate Nurse Unit Managers at the Victorian Virtual Emergency Department.
And I'm Hayley Gray and I'm the Nurse Unit Manager of the Virtual ED. So today we're here to tell you all about the VVED, so the evolution, where we've come from and where we are today. So providing some data and some stats, and we'll hear from some of our key clinicians and some external stakeholders as well. We'll speak about our workforce, some of the challenges we've faced, and we'll show you a demonstration of the patient journey into the virtual ED and some of our future plans as well. So we are the Victorian Virtual Emergency Department. It's a free and easily accessible healthcare option for anyone that's currently within Victoria or in the bordering towns. So it's for non-life-threatening conditions where we have video consults with registered nurses, doctors and specialised nurse practitioners. So with the aim to improve accessibility and equity in healthcare to all Victorians, especially those within rural and regional areas. Sorry, thank you. Is that better? Yeah. So it's accessible via self-registration, so anyone within Victoria can register for themselves or their family members, and also healthcare professionals can register to use the service. So the virtual ED first came about during COVID, and which was the vision of the Director of Virtual ED, Dr. Lauren Scher. We'll hear from her now.
I'm an emergency physician and paediatric emergency physician based at the Northern Hospital, and I'm the Director of the Victorian Virtual ED. I guess my original vision for the virtual ED was, more locally based. We were, facing the realities of COVID coming to our shores, and the idea really came out of a way of supporting the local hospital and the local community, and best addressing their healthcare needs. So we really wanted our community to feel like they would be able to have someone to talk to and discuss their medical conditions so they could make informed decisions about whether to come into hospital or not. But we were also kind of trying to rescue the emergency department because we were under the pump and we were the epicenter for COVID. So we were obviously trying to keep those patients that didn't need to come in from coming in. So the vision was, small. Did I ever think we would be a statewide service? I hoped we would become a statewide service, but I didn't initially think that was going to be the case.
So as Lauren said, in 2020, Virtual ED came along with COVID, and Virtual ED back then was called Northern Health Virtual Triage, and this is a really small team working upstairs on top of the Northern Health Emergency Department. It consisted of 1 nurse and 1 doctor.
So as Viv said, it first began within the emergency department. So we just had the one doctor and the one nurse, and they were just doing the afternoon shifts, which was the busiest period in our hospital. So it was managed within the emergency department with their workforce. So Natalie's one of our nurses who's been with us since the very beginning of virtual triage. She can tell us all about those early days.
Started at the top of the Northern Health's ED department. It was a very small office, and it was just consisted of the triage nurse and the consultant, and we'd have a shared desk. Basically, the triage nurse would assess the patient, and if the consultant deemed the patient appropriate to come in, they would then come in, and the triage nurse would become their primary nurse. I really enjoyed the change, especially because the rollout was during the peak COVID time, so it was good to get off the floor and away from the chaos. So I really enjoyed the diversity of the role, being clinical but not so much on the floor. It's been great to see the growth of the department, so going from like a shared space with consultant to now having soundproof pods and a ever-growing staff, so it's been really good.
Fantastic. So there's two pathways into virtual ED. We've got our self-referral pathway. This is what sets us aside from other virtual EDs. Anyone in the state of Victoria can register. And here a patient signs on or registers at vved.org.au. They're sent a direct link to their mobile phone, which drops them into a nurse-manned waiting room. Here, the nurse will go through an assessment with them and triage them. Then they'll provide them with a disposition, which is based on that assessment and their acuity. So if they're suitable for video consult, they'll go through to talk to one of our doctors or one of our clinicians, or they can go to the emergency department or link in with other primary healthcare services like priority primary care centres. Or they can be provided with self-care advice and self-management advice and lift that health literacy there.
So as Viv said, our self-registered patients are seen by our registered nurses. So they conduct their video consult and conduct their assessment and then triage, so to determine the acuity of their condition and the best disposition for these patients. So we have 4 categories of triage within virtual ED. So category 1s are actually sent straight into the emergency department. Category 2s and 3s are seen within the VVED. So Cat 2s is a priority by our medical team, and Cat 3s are seen within an hour by our medical team, and our Cat 4s are seen just by the nurse and managed by them entirely. So providing that really strong nursing advice, education, and referring on to community services such as back to their pharmacist, potentially to their GP.
But as we know, patients don't always understand their acuity of their conditions. And that's from those real high acuity walk-in chest pains, which are direct to resus, to those low acuity Cat 5s that want or need a repeat script. This is some of our non-life threatening conditions. I'm not sure if you guys can see that very clearly. We also have a case study of an 18-month-old girl who was self-registered by her parents. Her parents had been off and seen their GP a few days earlier, and they were feeling a bit more concerned because she wasn't getting better. On the registration portal, it asks for a few basic words on what your signs and symptoms are. And from memory, it was something like cold hands, cold feet, lethargic. Seeing the age, marrying up those symptoms, big red flags. So the ANUM can see that. And in this case, she pulled the patient from the Health Direct waiting queue and got a paediatric emergency physician involved early on. From that, the PEM had a look at the baby and pretty much got AV involved instantly, and she was whisked away to Monash Children's and intubated for invasive group strep A. So she did make a remarkable recovery thanks to that early intervention, or that recognition from the parents, that early intervention of using our service, and then of course the Monash Children's.
So self-registrations to the virtual ED account for 50% of all registrations each day. So at the moment we're seeing about 400 patients, so that's 200 patients each day are seen by our nursing team and triaged accordingly. So per triage category, so about 2% are sent directly from the nurse into the emergency departments, and 76% are seen by the nurse and then seen by our medical team. And the nurse is caring for 22% of those patients entirely, so directing them back into community services.
Fantastic, and we've got the second pathway, which is our Ambulance Victoria, or our healthcare professional pathway. Here, it was originally made for Ambulance Victoria on scene, so they would deem that the patient is suitable for a video consult. They would register the patient, get sent a link which drops them directly into a clinician-manned waiting room. Okay, so from that, they have that clinician to clinician handover where our doctors and our clinicians can help manage that care for that patient at home and keep them out of the emergency department and free that on-road crew up for more jobs, basically.
So the initial partnership with Ambulance Victoria formed in October 2021. So the aim was really to support those paramedics and the already overwhelmed emergency departments right across the state. So really to keep those ambulances available for emergencies. So VVED and AV have been able to support one another, really reducing those unnecessary transfers, but still providing that appropriate care that those patients do require. So one of our paramedics that utilises the virtual ED quite often is able to tell us all about how VVED's helped them manage their patients effectively.
It's proven to be an incredible resource for on-road paramedics. The technology provides us the ability to easily liaise with the VVE doctors for advice, management and referrals. Many times we find ourselves with patients that are not requiring emergency care but do need a doctor review. The VVED supports Ambulance Victoria to safely manage these low acuity call-outs and safety netting these patients to ensure they do receive appropriate care. Recently I attended a 45-year-old female with gastro-like symptoms. With the VVED doctor's support, we were able to administer IV fluids and antiemetic, with the patient being treated at home and referred on to her LMO. The consultation with the VVED doctor ultimately saved us an enormous amount of time with what would have otherwise been a transport to a hospital. This keeps us more readily available to attend those emergency call-outs. This is just one of the many successful outcomes of working closely with the VVED to provide best patient outcomes for the community.
Perfect. So, Hayley, how many patients has virtual ED seen so far?
So we've just seen over 150,000 since commencing.
Yeah, and how many of those have been Ambulance Victoria?
So 30% of our presentations to the virtual ED each day are from paramedics, and that equals, so far we've seen 39,000 Ambulance Victoria registrations.
And how many have we kept at home?
So 81%, so which translates to 32,000 ambulances have been able to return to the road and be available for those emergencies.
Okay, great. So looking at our timeline, December 2021, VVED had really outgrown its space. Hayley, you joined as NUM as Nurse Unit Manager in January 2022. Can you tell us a bit about the space of what was virtual triage at that point in time?
So due to the success of the original virtual triage pilot, VVED quickly outgrew itself, whereby we were sitting in the emergency department, and we expanded from that initial 8 hours to a 24/7 model. So we increased our staffing from doctors from 8 a.m. to 11:30 p.m, which we now have 24/7, and we had our specialist nurse practitioners covering overnight at this stage. In February 2022, we received government funding to become a standalone department and to service the entire state of Victoria. So we rolled this out in a phased approach to really understand what each area across the state required, understand each other's limitations, each other's capabilities, and really build those relationships. For some areas needed additional support in different ways. And as you can see, this is our rollout across the state.
I think everyone would agree it's a pretty impressive footprint that we look after. When I first came to virtual ED, we only employed critical care RNs who were trained with ATS. I know that nursing recruitment was definitely a challenge at that point in time.
It absolutely was. As we all know, there is a nursing workforce shortage everywhere. So it was important for me to view my workforce as a workforce that was not afraid of change and that was highly adaptable and could problem solve and act upon challenges. It was imperative that I invested in a team that was adaptable and embraced cultural transformation. And as you mentioned, there has been and there still is a workforce shortage everywhere. So it was very apparent that the value of our staff was in our experienced registered nurses. So as we'd exhausted all our critical care nurses within our area, so we had to start thinking outside our catchment. From here, we implemented as a virtual service work from home capabilities, so we're able to hire experienced registered nurses from all across the state of Victoria. And it was also really important for us to understand and provide the staff with what was important for them, a work-life balance and the flexibility of work from home arrangements. We identified that it was a challenge with how we structured our department, being a new service, and we realised that we needed to structure our department very similar to that of the physical ED, with our shifts and also our recruitment. So Kathy's one of our ANUMs who can tell us about the Associate Nurse Unit Manager role within the virtual ED.
What an amazing opportunity it would be to be part of such an innovative change in healthcare, being a part of a service that's able to help decrease the demand on emergency departments, at the same time increasing health literacy of Victorians. So as an Associate Nurse Unit Manager at VVED, I work alongside an amazing team of nurses, nurse practitioners, doctors and clerical staff. My role as an ANUM encompasses a variety of responsibilities. Each shift we provide full oversight and management of patient flow. We run multiple nursing and medical huddles during the shift to disseminate information. And because we are virtual, these huddles also provide a nice opportunity for us to get to see each other and have a little chat. The ANUMs are one of the main points of contact for staff as well as patients and other healthcare professionals such as paramedics, aged care facilities and so forth. We also manage staffing, ensuring that we have adequate provision of resources each shift. One thing that I really enjoy about being ANUM is being a clinical resource to the nurses, so assisting them with their consults when needed. We also run educational in-services for nursing staff, and we each lead a quality and safety standard portfolio. It's been an incredible year for me growing the ANUM role and getting to work with such an amazing team. I can't wait to see what's to come for VVED.
Is anyone here from Austin Health over in Melbourne? You might recognise Kathy. We're very fortunate to have her come over to virtual ED and work with us. She's a real asset to our team. Kathy came after our big move, which was a really big thing for virtual ED. Can you tell us a bit more?
So this is when we moved to our new purpose-built space that you can see here. We've got these soundproof pods, so therefore staff no longer needed to wear their headphones and everyone yelling over one another. They also provide privacy and confidentiality, so when the staff are working on site, clinicians, doctors, anyone, they come in and sit and conduct their consults within here. It was also around this time when we moved that we also, our milestone of seeing 100,000 patients.
100,000 patients for us was a really big day, as was our big move. We also talked briefly about our second entry pathway before, I mainly focused on Ambulance Victoria, but this is also for other healthcare professionals.
So the other healthcare professionals that this pathway includes, so your urgent care centres, general practitioners can call through as well with their patients, AV triage services, and also residential aged care facility staff can call on behalf of their residents. So providing them in the same way that Ambulance Victoria has access straight to the clinicians. So providing them with 24/7 access so they're able to make most appropriate decisions and reduce those transfers for these patients. We have quite a diverse medical workforce to manage the many different cohorts of patients and presentations that come through. So Jason Nebbs is our VVED Director of Workforce and can explain that all to us.
My name is Jason Nebbs. I'm an emergency physician here at Victorian Virtual ED. It's a very diverse workforce that we have in Victorian Virtual ED. We have a mix of many clinicians. We've got emergency physicians, we've got paediatric emergency physicians, we have paediatricians, we have GPs, we have GP, ED, paediatric registrars. We have nurse practitioners with a variety of specialty and general experience, including paediatric nurse pracs, aged care, palliative care specialist nurse pracs, as well as general nurse practitioners as well. So yes, it's a very diverse workforce that we have, providing 24/7 cover for the patients of Victoria.
Okay. Until recently, we did have our early treatment therapy team, and this team supported Victoria in providing early access to COVID antiviral medication to help reduce the hospitalisation.
So that's another arm of the VVED. We have the VVET, which is the Victorian Virtual Early Treatments Team, and they provide a detailed and nuanced service for antiviral prescribing for COVID positive patients within Victoria. We have a group of clinicians that perform those consults, including nurse pracs, some GPs and some specialist emergency physicians as well, supported by Alex Brown, who's our pharmacist, who's a dedicated resource for the VVED and the VVET. So that's a nuanced service that we provide, and with the decreasing ability of the community to actually access some of the antiviral services within the state at the moment, the VVET is providing a statewide service for Victoria at the moment.
Virtual ED also supports the state's urgent care centres.
That is a increasing body of work that we're seeing at the moment. We have a large and increasing number of urgent care centres that are seeking help from the VVED to cover regional and rural workforce shortages, especially with medical support and nurse practitioner cover. So our numbers of urgent care patients through virtual ED in the last 3 or 4 months especially has increased dramatically. We're seeing large numbers of nursing staff from the regional and rural urgent cares calling in to register their patients with virtual, so that we can provide them some medical support for anything from paediatric patients with croup through to aged care, falls, query fractures, and shortness of breath, chest pain, etc. And we try and provide as nuanced service and support to those nursing staff and those regional patients to the best of our ability.
Some urgent care data there. So urgent cares equate to about 8% of our registrations each day. So at the moment we're averaging about 30 each day. So 19% of these registrations do require transfer to the emergency department. However, 79% have been able to be managed by the virtual ED. So these patients potentially likely would have had to be transferred to those high, larger health services for that ongoing care. However, we've been able to keep them within their community and in their area and receive the care that they require with the support of the virtual ED.
Virtual ED also supports residential aged care facilities, and we have Dr. Alan Jardine, who leads this portfolio and champions this space. He's just going to tell us a little bit more about it.
Department, we try to keep patients at home in their aged care facility when it's safe and appropriate to do so. In order to make these decisions, we take into account a number of factors, including the acute presentation, medical comorbidities, and the wishes of the patient and their family members. There's been numerous occasions in which the virtual emergency department has had a positive impact in the care of patients in the aged care setting. One example that I can share with you, it took place just the other night. It was 3 o'clock in the morning and we had a call from a concerned nurse at an aged care facility. She had an 89-year-old lady who'd become quite short of breath over the course of the evening. Upon assessment, it was clear that this patient was approaching the end of life, and rapidly so. I was able to make contact with the patient's family and medical power of attorney. I explained to them the situation, that their mother was rapidly approaching the end of life, and we talked through the options: keeping her at home, comfortable with the use of appropriate medications, or transferring her to hospital for further investigation and management there. The family were quick to come to the conclusion that their mother would rather stay at home, where she was known to the facility, where she was comfortable, and where they would hopefully be able to attend to be at her bedside. Once this decision had been made, we were able to initiate the appropriate palliative care medications, and her family were able to be at her bedside when she passed away later that morning. This is just one of many examples where the virtual emergency department has been able to have a meaningful impact in the aged care setting.
aged care referrals to the virtual ED are about 7% of registrations each day. So 72% of these do not require transfer to the ED, and as Alan said, they're able to remain within their facility. So able to support those nursing staff to manage the residents within their homes and reduce the stress and anxiety of a transfer. So as Alan also spoke about, VVED is able to provide palliative care management and commence palliative care measures with our specialist aged and palliative care staff within the VVED. We also identified high-risk populations, which included our over 65-year-olds and our First Nations communities. We identified that these cohorts have a much lower engagement in healthcare and with their follow-up plans. So we implemented post-consult reviews, so within 24 hours all of these patients receive a call to really mitigate this risk. In recent times, we've also implemented a review clinic for our high-risk patients, where our patients that are suitable are followed up by the virtual ED and booked in for an appointment the next day. So reviews such as X-ray reviews, paediatric fluid reviews, and results-related reviews.
And those high-risk patients, we are receiving really good feedback from these patients, and the feedback is around care resolution and feeling more connected to healthcare services. Looking back at our timeline now takes us to December 2022, and Christmas was a huge challenge for us at Virtual ED.
We did not expect our presentations to literally double overnight. We went from seeing 300 patients to 600, but with Northern Health support, we were able to be flexible and adaptable to the service demand. This allowed us to instantly act on challenges and once again transform the way that the VVED operated in a patient-led space. It was an absolute challenge, but a challenge that we met. The entire team embraced the challenges and changes as we implemented these on the run.
Digital health, there's definitely a lot of changes that go on at Virtual ED and they happen really quickly. Okay, so let's see how registration and how Virtual ED looks from a patient's point of view.
On how patients can complete a self-registration for the Victorian Virtual Emergency Department. There are two ways to access the registration form. Patients can visit our website, vved.org.au, or can scan the QR code on one of our magnets. This will open to the registration form where patients can select their preferred language for the form. Patients will then be prompted throughout the form to enter their details such as their name, contact details, and a series of screening questions. Once the registration is complete, an SMS and email will be sent to the patient containing a link to the VVED waiting room. The patient will need to confirm their details to join the virtual waiting room. Here, a clinician will join the patient to begin the consultation.
As you can see, it's quite straightforward. The registration prompts you all the way through. So as Megan said, it's available to be translated into 20 different languages, and the registration form will actually detect the language that your phone is in, and you can also request an interpreter from in there. So a project we actually launched recently has been our virtual liaison nurse role, and Abby, our virtual clinical nurse educator, led this, and it was very successful, and will tell us all about it.
The virtual liaison nurse role involves being situated down in the emergency department and working really closely with the triage nurses to assist in identifying patients who are appropriate for virtual ED. So what they would do is explain virtual ED to the patient and gain their consent, and then we have a private area in the emergency department where we can set the patient up with a tablet and they are seen in a timely manner by one of our virtual ED clinicians. Our clinicians will treat these patients like any other patient that comes through virtual ED, so they can do their medical assessment, provide medical advice, and provide things like e-scripts, referrals for radiology and pathology tests, as well as referrals to other community services like primary priority care centres, respiratory clinics, and GP clinics. Across the 8-week pilot, we pulled a total of 490 patients from the ED to be seen by virtual ED, and of those 490, 83% of those were discharged out of the emergency department, and we're super happy with those numbers.
So we've been able to provide similar services with other hospitals. Our friend from Austin up the back there, we have implemented, or Austin has implemented, a booth where the triage nurse can directly refer from Austin Triage to Virtual ED. The patient enters the booth, they can go through their consult there, so they have a space for privacy and confidentiality.
So at the moment, we're seeing on average 450 patients per day, and 45% of those are paediatrics. Self-registrations make up 60% and healthcare professionals 40%. And overall, 85% of the patients that present into the Virtual ED are able to be managed entirely by the Virtual ED. So recently, also as a new service, we've implemented many new roles. Viv has recently commenced a new role. Tell us all about it, Viv.
Yeah. So as at Virtual ED, every ANUM has a portfolio with the NSQHS standards. My portfolio is Standard 1, Clinical Governance, so Governance, Leadership and Culture. In my role, I work in the quality team there. So being a new service, it was about building really strong frameworks for safe practice and safe delivery of care. In that, it involves a lot of policy and procedure writing, making sure we're getting our guidelines right for that safe care practice. A lot of quality improvements, risk identification and analysis, and risk mitigation strategies. So we have lots of different teams inside Virtual ED which help build this really strong service for the state.
We've also recently implemented our virtual extended ward for our paediatrics. So our medical team are able to, and also from Northern Health, admit paediatric patients that fit the specific criteria. So admit them to our virtual ward, whereby they are then able to contact our doctors at all times to be reviewed virtually. So it has now been 3 years since it all first began, the Virtual ED, and this is just another step in the Virtual ED becoming a virtual hospital, as in Lauren's initial vision. Let's hear from Lauren to speak about our future plans.
Future vision is, I guess, a virtual hospital for the state. I really want us to diversify and not be just thinking in the critical care space, but also thinking, I guess, in terms of subspecialties, and I guess deliverance of healthcare across all the borders. When I say borders in Victoria, although, we could take over the world. I guess the reality with the virtual means we recognise that there just is such a great impact, particularly for patients that just don't have that access to equitable healthcare. And that's, the paediatric patient that's been waiting for months to see a paediatrician, or somebody sitting in an aged care facility who really needs a specialist opinion. And we recognise that we're able to cross those borders and boundaries and deliver that healthcare to those patients. And it would be really great, to my mind, if we could extend that beyond just Virtual ED and deliver that specialty healthcare to those areas of need that didn't have to necessarily be in the sort of extreme acute or subacute space.
So the Virtual ED to date has proven its success as evidenced by the data, but also by the positive patient feedback. These testaments prove the service is a success amongst the community and a direct reflection of the project, the team and the commitment of all stakeholders. We and Northern Health are very proud to be growing the Virtual ED, and we thank you all for having us today.
Thank you both very much there. We've got time for questions.
Okay.
Just we are asking questions. Do you guys mind just repeating them just so that people streaming can?
Yep.
Yeah. Awesome.
All right, I'll repeat your answer. Okay, yep. Do we have a minimum age? No. Anyone? Yeah. 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 So the question was, do you have a physical space? So no. So we'd send them on to, depending on the acuity, we'd link them in with a GP or priority primary care centres we've got in Victoria. So we actually liaise really closely with them, find where the closest area is for them to attend, and we will sort of refer them on to them, let them know this kid's coming in, can you check out their ears, and then they'll sort that out. Yeah. But otherwise, if they need the ED, they'll have to go in. to there. Yeah. Yep. No. Across the state, so they're all different times. And then I suppose it's determining, do they need that right now or can that wait for 6 hours? We'll sort you out an appointment with them and they'll know you're coming. Yep. I think that's, yeah, just down here. The question was, is this option well known to the public? So rolling out to the state, we did it in phases so that we weren't completely overwhelmed, and we're still probably doing that as well. So at the moment we've reached out to pretty much all healthcare professionals, urgent care centres across the state, and in the public we're sort of a lot of word of mouth as well, because otherwise the floodgates might just come. We're probably not ready for that. We've seen that in Christmas. We weren't ready, but we got it done. So the question was, how do we ensure healthcare professionals are compliant coming to us and not going straight to the emergency? Was that right? Yes, sorry. So I suppose through education, we have found that some are reluctant to use it. Some people, don't. It's a new service anyway for the whole state, for everyone that, why would you go trust this service, that stuff as well. So healthcare professionals, once they become familiar, what we can do, what we can't do. So it's been a lot of education. There is still, I suppose there's a lot of teams, especially like quality teams, working on ones that do get transferred to the ED that didn't quite need to be there. And, then just going out, reaching out to them, why didn't you potentially come to us? How can we support you to do that in future? And the same with the public, it's a lot of, reassuring people that what we can do, what we can't do, we understand our limitations as well, what we have to send in as well. Yeah.
Do you mean like AV secondary triage?
So like, oh, yep. So AV triage, so basically they'll get put through to AV triage and speak to the paramedic or whoever they speak through in there. We actually partner really closely with them as well. They'll refer straight into us as well, but we haven't sort of taken that over or anything like that. We're working with them because it already exists. Yeah.
Yeah. Yep, that is our AV triage. So they have nurses there, paramedics, healthcare, and they will go through a triage with them and say, hey, you're most suitable for virtual ED. They will drop into that clinician manned waiting room because they've effectively already been kind of triaged, and they will see a clinician from there. They'll skip the nursing triage and they'll see a clinician direct. Oh, yeah, I would have to pull that up from our reporting portal.
9% of AV triage that we actually end up sending an ambulance to those ones or sending into ED by private car as well. So we do that as well. So, they will refer in because they've got a form very similar to Ambulance Victoria. But yeah, 9% out of those ones from AV triage go through or need to attend emergency. Yeah. Oh gosh. No. Yeah, no, not at this stage, just because in Victoria none of the hospitals or anything's all linked, unfortunately. But we have just moved on to EMR, so electronic medical records, so and My Health Records. So we upload straight into My Health Records so others can grab those. But we do share on as well patient notes, especially if they're going via ambulance and that sort of thing, so that the hospital understands why they've come in. Yeah. Oh yeah, right up the back in the red.
Sorry, and then you.
I meant to be repeating the questions. Sorry.
Can you repeat that?
We're meant to be calling out the questions.
sorry, I was just asking if your clinicians are linked in with VST as well, or whether that's just completely separate, or whether any of your emergency department doctors are linked in with the VST network.
VST?
Victorian Stroke Telehealth for urgent cares in rural and remote locations.
No.
I'm not sure.
So the question was, are we linked in with Victorian Stroke team? Is that right?
Yeah, the VST, so Telehealth Stroke Network for rural and remote Victoria, and urgent cares that don't have stroke facilities where clinicians can seek resources from other clinicians that are specialised in larger EDs, for example.
Yeah. No, we're not linked into that, but we will make note of that,
Yeah, thank
Laura.
you.
Yeah, in the middle. So the question was, are we linked in with, prior to dispatch of the ambulance, linking in with that initial phone call to 000? Yeah. So we work very closely with Ambulance Victoria. They already have their systems in place, and we're trying to support one another with that. So I suppose yes and no in a way. Yep. We're working alongside Victoria, Ambulance Victoria to support them in that as well. Yeah. Yep. Yep, so do we have a follow-up service? So yes, we've got a review clinic. So those patients that are identified that need that follow-up will be booked in the next day, and our clinicians call back those patients, and or they've booked in for a time, they have another video consult. Let's review your x-ray together, let's review your bloods, let's see how you went with that fluid resus, basically. How's the child going? Yeah. Yeah. Sorry, just over in the red. Yeah. Yeah, so how do hospitals utilise our service and then give medications to the patients that are with you? Yes, so we can send, we can do blood slips, pathology requests, radiology requests, and medication charts as well, and phone orders. So a lot of like urgent cares, I'm not sure where you're from, but yeah, the urgent care centres, they'll do phone orders over those and then send through, we've got specific medication charts and that authorised, yeah. Yeah, just stand here. So yeah, VBED is not limited by Medicare. Free for literally anyone. All you have to be is in Victoria, yeah, or on those bordering towns. Yeah, yeah, anyone, yeah. Sorry, just behind.
I think IT would be our biggest challenges. Being a new digital health service, it's really important that our systems remain capable, adaptive and responsive. And sometimes when we have been overwhelmed, that doesn't always meet the standard that we're wanting. So we work really closely with Northern Health IT services, as well as our vendors, the clinician and Health Direct. We have very close relationships, and we basically have instant escalation pathways where if our registration portal goes down, we do have guidelines and backups on how to get registrations in. Our service doesn't shut. We saw at Christmas time, we had a massive surge of patients. Health Direct wasn't performing to meet the surge because obviously no one knew that it was going to happen. And we have workarounds, and that's one great thing about virtual ED. We're really quick to flip it, call a quick huddle and say, guys, this is what we're doing because XYZ isn't working. It doesn't happen often, which is really good, but IT definitely one of our biggest challenges. Yeah, I can't deny it. Yeah. great for infection control. And that's where it all came about, out of COVID, keeping people at home, reducing those hospitalisations, keeping EDs for emergencies, right person, right place, right time situation, and reducing the risk of, we know that Victoria or Melbourne had the longest lockdowns in the world. So it definitely helped reduce,
Yes, yep. So we work really closely with all the states, and they've all got their own little virtual ED going at the moment. So I work really closely with the other nurse unit managers, seeing what works, what doesn't. What each state is all different across the states. But yes, very closely, and even across overseas and stuff, because a few of them are quite ahead of us.
So do you, sorry, just so I can clarify, if the patient presents to a healthcare service and then they come to virtual ED?
No. Send someone to them.
Yep. So we would do that, and then we would say, yes, you need to present to your nearest health service.
Yeah.
No, we don't have that capability. Yeah, that sounds like a HIF type situation. Yeah, we don't have that capability. We are literally a virtual service.
But we do link in with HIF across the state. So anyone that, say, a patient is in their HIF, hospital in the home, that is, or residential in reach as well, we do referrals out. So anyone that's in a current, catchment, that's already in with that, we will let them know to go check up on this patient, this is what they came in for, just give them a rundown and also a summary of what their issue was, basically, presenting a complaint. Yeah, we've definitely thought about it. Yeah, it's definitely, on the radar. Yeah. All right, no more questions. Done. Thank you.
All right, let's hear it for Hayley and Viv. Thank you both very much, and well done for getting absolutely grilled by a room of 100 people. So I think that deserves another round of applause. So let's take a 20-minute break. Still plenty of food, tea and coffee out the front. Just a reminder to get those photos in. Today's prize is 2 vouchers to the Trans Resort Spa. So for anyone looking a bit sore or would like a massage, maybe, quickly take a photo, send it through, and we'll be drawing those after the break. All right, enjoy. Welcome back, everyone. Hopefully you've all had a chance to get some coffee into you, because it is going to be time for our photo competition. So, rules of this one. Loudest cheer gets the 2 spa vouchers. So if you're here by yourself, maybe find someone to cheer for you and you can share those vouchers. So it's 2 spa vouchers for the Trans Resort, very kindly donated by Everest Wealth. So, are we ready? First one. Oh, that's just me. Oop, gone too far. All right, what do you reckon? Yeah, that's lovely. That is lovely, yeah. All right, next up. Oh, it's pretty mellow at the moment. A few golf claps. Oh, it's so far, yeah. We know that they're in the crowd today. And wait for it. And there we go. So what do we reckon? The monkey video? Yeah. All right. I think the monkey video is a winner there. Well done. Please see myself or Dylan after. And probably quite fitting after watching that we are going to be talking about eye emergencies now. Yeah, thanks. So let's welcome Cherie and Jacqueline up to the stage. You'll probably see their names a few times on the timetable. We're very fortunate to have them present for us twice during this week, and they're also running the workshop tomorrow. So let's hear it for Cherie and Jacqueline.
Morning, everybody. I'm Jacqueline. This is Cherie. We're both nurse practitioners in emergency. I think they calculated we've got 70 years experience between us, which is a bit sad. We're at Armidale in WA, so it's one of the metro EDs, but we're teaching but not tertiary. So we see a lot of eye injuries. That's a big cohort of what we see each day. So, just some basic anatomy of the eye. Look, we all know the eye. We've got our globe, we've got our posterior chamber, the anterior chamber, the cornea with the lens. Not going to get too complicated on that. So we're mainly going to be focusing on injuries that are affecting the anterior part of the eye. It's really important in your primary assessment, and this is whether you're in an ambulance, if you're out in the bush, if you're in ED, that you get a really good history of how either the injury occurred or what symptoms they've been having. You know, when did it start? Some people present pretty much straight away, you know, if they've got a piece of wood sticking out their eye. Some other people may have a painful eye. It's been going on for a week, 2 weeks. They've seen their GP. GP said, oh yeah, go to the chemist and get some Chlorsic. Hasn't really done a fantastic assessment. And then last port of call is, you know, coming to emergency. So mechanism of injury. Sometimes people will ascribe their pain and their symptoms to an event. And it's nice to get that information, but sometimes our patients are putting 2 and 2 together and getting 4. So you kind of need to talk to them about what were they doing prior to the injury, or, you know, their symptoms. And sometimes some eye problems don't show up till a day later, or sometimes even a few days later. So, and what are their signs and symptoms? Like, is this going to be an issue with the eye, or is it something else? We get a lot of, because we work in ambulatory care, a lot of eye problems come through, and when you actually talk to the patient, it's obviously a neurological problem, or they've got some visual loss, you know, like with your retinal artery occlusions. That's sudden visual loss. That's not an injury or an infection.
So just because you think it's an eye and it's being triaged as an eye, and most of us in the ED setting, oh, hang on, tell me, who's out remote rural on their own? Cool, there's a few. Rural hospital, and you're the ED lead. Emergency department.
Oh, yes.
Ambulance.
Good.
Okay, so most of us are buddying with somebody and you've got bounce off and you get a bit of a triage. Don't take the triage as gospel. Always think about your differentials, okay?
Which is why you do your own history. Don't read the triage form. Have they had any recent trauma? And sometimes they don't even really remember the trauma. Their eye became sore on Tuesday, but when you take them back a couple of days, you'll find that on Saturday or Sunday they were welding, or they were working under something and they were drilling. So sometimes you have to really try and get as broad a history as possible so that you can try and work out what's happening. Have they had any recent eye surgery? That's really important, particularly when we get further down when you've got your retrobulbar hemorrhage. Sorry, forgetting my clicker. So when you're assessing, the first thing that you do with an eye, and this is in a hospital setting, obviously you're not going to do this out on the road or in somebody's home, is you record their visual acuity. Now that is a really important part of your documentation, because if you apply an intervention, you know, you may be bringing them back for review or they're going somewhere else for a review down the track, that tells you whether your intervention is working or not. You know, or you may see someone, really good visual acuity, they're back a couple of days later, visual acuity has gone right down. So really, really important to record that on your first visit. You also examine their unaffected eye, because you need to be able to have a comparison. And I've got a couple of things here that I did not put on the slide, I'm sorry. So you need to check their eye movements, particularly with trauma, because if they've got a fracture anywhere within the orbit, the muscle can get caught in the fracture. It will affect the eye movements. And once again, you're doing both the eyes together. You're going to look at the orbit, so the outside of the eye, and also on their eyelids. So you're looking for drooping, you're looking for edema, you're looking for any erythema. Sorry? Foreign bodies, yes, some of them are obvious. Looking at the conjunctiva and the sclera, is there any injection there? Is it edematous? Is it red? Do they have any flushing around the limbus of the iris? So that's just the rim of the iris. We're going to look at the cornea. Is it clear? Is there any obvious foreign bodies on the cornea? Is there any opacity on the cornea? A lot of your corneal ulcers will present as being opaque. These are all things that you can look at without a slit lamp, because we're presuming for this, not everybody's got access. We look at the anterior chamber, which is just essentially in front of the pupil of the eye, and we're looking for any blood or pus in the anterior chamber. And we're looking at the pupil. Is it reactive? If they have an injury, is it perfectly round? Do we have some disfigurement to the pupil? You know, I've had patients have elliptical pupils because they've got an injury there. If they've presented with a painful red eye and you're not sure that it's actually an injury or an infection, you need to test their pressures if you can. Obviously, once again, that's an ED thing, so you'll be testing them bilaterally with a tono pen or whatever means you have to test their pressures. The other thing that we will do is we're going to evert the eyelid. So there's a little muscle that runs along your eyelid. So essentially, you pop a cotton bud transversely so that you isolate that muscle. You pull their lashes and you pull it back over, and that will flip the eyelid inside out. And then you can have a good look underneath the eyelid. Is there any foreign bodies there? Any signs of infection? Is there any inflammation? I had a patient referred by GP, 10 days of corneal abrasion, wasn't getting better, clawsick. GP hadn't averted the eyelid, and it's always part of my initial assessment. And there's a little foreign body, and every time they blinked, it was scratching the eye. 10 days, this poor patient. And I took it out, and they went, "Oh, I think I might have got some toast in my eye." It's just like, people get all sorts of things. You know, things like bits of contact lens break off. Just even simple things like an eyelash can get stuck under there, and every time they blink, it scrapes the cornea. It's really painful for the patient, and it's not going to get any better. You've got to remove the source of the problem. So once you've done your primary... Oh, why is that not coming up? Oh, hang on. So once you've done your primary, it's always good to go back and talk to them again, because you find things on your primary assessment that they didn't even know were there. I had a patient came in, once again from a GP, with persistent conjunctivitis, and they had an abscess under their upper eyelid. So it's always good once you've had a look, because then you can start saying things to the patient that are more focused, more relevant to what you think that you found. So you get your first story, you examine, but you go back and you just go over it again, just so you don't miss anything. Sometimes they change their story because you found whatever on your primary assessment. You go, oh, and then because they've already put 2 and 2 together and got 5, they suddenly retract from their initial thoughts and they start getting on board with you and they give you more of a story. And sometimes their condition may have changed. You know, the one thing I love is when you put tetracaine in their eyes and all of a sudden they're like, oh, you fixed the problem, it doesn't hurt anymore.
Now,
it's like,
that's any of the canes. There's tetracaine, amethicane, pilocaine. So all of them are an anaesthetic eye drop, and all of them do essentially the same thing, anaesthetise the eye.
and the patient feels better and they think you're wonderful. So we're just going to go through some of the injuries. So burns to the eye, really common. So you've got your chemical burns, and there's a lot of, we'll just flip through in a minute in some sources of potential injury. You've got your thermal burns, and you've also got your radiation burns. So this is good if any of you are going to go to Risutsu out in the snow to know this. Take some Clawsic with you. Sorry. Your alkaline burns, I think, are actually the worst. They cause a huge pH change in the eye. The pH of the eye sits around about 7.4. That's where it likes to be. Alkaline causes some really nasty eye injuries, and there's a lot of the cleaning products. We get a lot of people come in, they're commercial cleaners. They get the cleaning products in their eyes. Kids, yeah, you know, they get squirty things and they just squirt each other and themselves. Drain cleaners is another big one. These are usually splash injuries. Not so much the potash. Sparklers and flares, we don't get too many of those because fireworks, obviously, I don't know about the other states. In WA, they're illegal, but people do use flares. And lime is a big one. People mixing cement, plaster mortar, they get a splash in their eye and it's nasty. When they come in with a chemical burn, you must check the pH of the eyes before you do anything, and you check both. Even if the other eye is unaffected, you want to know what their normal pH is, and that gives you a really good guide, essentially, to how much irrigation you're going to have to do. Acids, a lot of things contain acids. Once again, your industrial cleaners. Bleach, we get a lot of people in that are bleaching their showers. They accidentally drink it because they think it's their water bottle, or they'll spray it in their eyes. Hydrofluoric acid is a nasty one. That is one that will keep on denaturing the protein. So we usually use a calcium gluconate, calcium gluconate gel on those to counteract the hydrofluoric acid. It's used a lot in industry. Where I work now, there's not much industry, but where I used to work was very close to an industrial strip, and we used to get the hydrofluoric acid burns. Acetic acid, your vinegar, and your hydrochloric acids. And a lot of people use that in their swimming pools, things like that. Once again, they're mixing chemicals. And this is what they can look like. So it's nasty, completely denatures the front of the cornea. You know, if you don't fix that they've lost their vision. It's just really, really nasty.
So this one would have had to have gone on for a corneal transplant. And where do we get our corneas from? Cadavers? People who've donated their organs, tissue.
This is what this burn looked like down the track. So as you can see, they're not going to have any vision through that. It's just completely opaque. So what are we going to do with these? So it's an ocular emergency. They should be getting treatment straight away, whether you're in ED, out in the field. So we need to know, when were they exposed to that chemical? How long were they exposed to it for? Was it just a quick splash? Did they get immersed? Was it, you know, a big face full of drums? I've had somebody where a drum's been dropped and just gone, and they've just been covered. And also, have they irrigated it already? You know, that's really important. But regardless of whether they've irrigated it already, that's what you're going to do. So if you're out in the field, just copious amounts of water. And we're not talking 5 minutes. We just keep going with it until you've got them to care. It's really, really important. If you're out in the field or you're not in the hospital setting, evert the eyelid, because the chemical can get caught in the fornices. If you're lucky enough, like in ED, we have a thing called a Morgan lens. The Morgan lens is great. It's like a contact lens, sits on the eyeball. It doesn't actually touch the eye. It floats on liquid, but it actually gets into all the fornices. Sometimes I've had patients, they've needed 3-4 litres through each eye. Keep going, keep going, keep going, until you've got their pH as far back to normal as possible. There have been cases of people having irrigation for 2 to 3 days just to try and restore that pH. I usually use Hartmann's for irrigation. It's the closest in tonicity and pH to the eye, but really it doesn't matter anything, even if it's plain old tap water. If that's all you've got to irrigate it. You know, and also when you evert that eyelid, if there's any particles or anything under there, get a cotton bud, sweep it. Okay, really uncomfortable for the patient, but really necessary, particularly if you've got things like concrete dust. You don't want to leave those in the eye. You need to take them out. Thermal burns. So cigarettes, not so much now because not so many people are smoking, but we just get a lot of kids standing there with a cigarette in their hand. Kid would walk into the cigarette, get a burn to the eye. Fat, people cooking, fat splashes up in the eye. So your major burns, fires and explosions. You know, if they've had something go off in their face. We're in Armidale, so there's lots of meth labs around there, so it's like... It's probably everywhere, but we are renowned for our Armageddon, we call it. Burns to the lid, we would treat the same as we would a skin burn. It is a skin burn. And corneal burns, you can literally see them on the cornea.
You get this blistery-looking chemosis, so the conjunctiva becomes like a liquid-filled blister, and it gets that big sometimes that you can hardly see the cornea or the pupil, and they can't close their eyelids, and the blister's pouring out of their eyelids. So, yeah.
So this is a fireworks burn, and you can see there that it has blistered, but that blister's de-roofed. So, but this is right over their visual field. You know, this, we will do the initial first aid, but these always have to go to a specialist, always. So a fat burn to the eye, you can see down the lower part of the iris, you've got that opacity there, the blistering. So the treatment for these. So flame injuries to the lids, we treat the same as a skin burn. We're going to do the irrigation, and then we're going to apply the cool saline compresses. Don't use ice packs. You're going to cause further thermal injury. Corneal exposure, like with that fireworks burn, we're going to put some ointment on. So that could either be your preservative-free, or you can use Clawsic ointment. I would use Clawsic if it was available because it's got that antibiotic component. And they need referral. Any burn to the eye needs referral. UV burns for you skiers going to Rusetsu. Wear your sunnies. So your UV burns can be from snow. It's light exposure if somebody's decided to watch the solar eclipse, or if, you know, they're welding, so your flash burns. They don't always have pain straight away. It kind of causes an inflammatory process on the cornea, and that kind of develops over time. So this is where it comes back to your history taking. Like, they're in pain 12 hours after sometimes the actual incident, but they've attributed it to something else that's happened in the meantime. Really, really painful, like super painful. They get photophobia with it, so totally intolerant to light. They feel like there's something stuck in their eye. You know, and they'll come and they're going, I've got something in my eye, something must have blown in my eye. Once again, back to your history, they've not done anything. Lots of tearings, very watery. And they get what they call a punctate keratitis. So punctate means spotty, like little spots. Oh, in a minute. She's telling me what to do. On the cornea. So if you have fluorescein and you have a blue light, because you don't have to have a slit lamp, you can fluorescein, use an ophthalmoscope. This is what it would look like. So it's widespread across the whole cornea, and it's little dots of light. Now, if it's a flash burn from welding, it's usually both eyes, and there will be a line where the eyelids were. So it's quite easy to see. You know, you've got part of the cornea is really inflamed, you've got this punctate uptake, and then the upper part of the cornea looks fine because they've kind of blinked reflexively and they've protected their eye partially. As I said, this is really, really painful, and you're going to put tetracaine or one of the other locals in their eye, and they're going to love you forever because they're pain-free. Do not, and I've seen doctors do this over and over again, give people local anaesthetic to take home to continue with. Why? It can lead to significant complications. They can get what they call a punctate keratitis, so inflammation, a punctate inflammation again. They've already got it, but this will make it worse. Persistent epithelial defects. So you get this stippling of the cornea. You can also get some opacity and thickening of the cornea as well. So we don't want to give these patients more problems what they've already got. It can cause corneal edema, which once again will affect their vision. They can get endothelial damage, and they can get ocular inflammation. So they get scleral injection and inflammation as well. So as much as I would love my patients to go home and be pain-free for a few days, they're just going to have to persist with oral painkillers, lubricating eye gels, things like that. And that's literally the treatment. Analgesia, so oral analgesia, chloramphenicol ointment. Usually we give that, it's QID, But what I'll often do with these injuries and also with abrasions is tell them to get some preservative-free lubricating eye gel or drops, and they can use that hourly. It keeps the front of the eye moist. If it's a gel, it helps fill in those little stromal defects that they have, so when they blink, they're not blinking against a rough surface. And pad the eye. They often get a lot of relief with that. I always pad my eyes when they've had local because I don't want them rubbing, and I just pad them for a couple of hours. Some do, some don't. That's my practice. It's probably from my bias, going back to the talk yesterday. So trauma to the orbit and the lids. So you've got your blunt orbital trauma, your orbital foreign bodies, lid lacerations, and your infections. And we'll probably have time for the infections. There's lots of slides. So your blunt orbital trauma, that can be fist balls, people are playing sport. You've got to kind of think of what sport are they playing, because if it's squash, that ball's small enough to fit into the orbit. If it's football, something like that, usually they're pretty well protected in the orbit. Golf balls, yeah, and they're high velocity. The cricket balls, very high velocity, and particularly if they're close to that ball. So you've got to consider the mechanism of the injury. If they're punched, was the person wearing any rings? Are there lacerations? And then we've got to look for the complications, and I'll go through those on the slides. The other thing, we've got to consider child abuse, which there was a slide, I must have skipped it. But when a child comes in, back to your history, very important, to consider, particularly on the age of the child, is the injury that they've had occur consistent with what that child would be doing, like any injury that we look at in children. I had a Down syndrome baby, probably 2 years old, came in and had a corneal abrasion, and the mother's like, I think they must have scratched their eye. And that was actually quite consistent. I didn't do a paediatric injury pro forma, but then that child started coming back with other injuries, when you start adding them all up, minor injuries. And it turned out that the aunt was abusing the child, and the corneal abrasion, because they ended up with several more, she was poking her fingers in the child's eye, which is just awful, so we always have to be mindful. So if you have a child with an eye injury, as I said, I was the first person that they'd presented to with an injury, but it's always helpful to look back in their history as well, like, why has this kid had 5 corneal abrasions in the last month? It's not possible that they keep doing it themselves. So this is what we call a retrobulbar hemorrhage. So this can occur after trauma, and it can also occur after surgery. So it's not actually bleeding within the globe itself, it's from the arteries at the sides of the eye in the musculature, but it leaks into the eye. It's an ocular emergency. These have to be drained immediately or ASAP. If not, if they're not managed, there's a 48% chance that 48% of people will lose their vision in their eye. That's huge numbers. If they have early intervention, early drainage, that number goes down to 0.2%. So it just shows that importance. And you've got to, once again, going back to their history, like somebody like me, I have no vision in my right eye. So if I have an injury to my left eye, and it's something that you can reduce my chances of losing my vision, I would be really grateful, and our patients would as well. So really, really important. And in all honesty, they're very rare, and I've never seen one. In 43 years, never seen one, 25 in ED, so yeah. This is one that we do see occasionally, which is a high femur. It's a blunt injury to the front of the eye, and it's bleeding into the anterior chamber. So that's the front of our eye bit there. Quite easy to see, unless they've got very dark eyes. Your dark brown eyes, it's very difficult to see. But definitely you need to look for that one. And we'll have a look at the treatment shortly. Blowout fractures of the orbit, and this is where we come to our ocular movements. So you need to check all directions, transversely, longitudinally, up into each corner, and just have a really good look. And do they have pain? Because if they've got a blowout fracture and their muscles caught, that's going to hurt them to move their eye. So it's a really helpful diagnostic tool, because then you can think, okay, they've probably got a blowout fracture, I need to CT this. So the treatment of blunt orbital trauma. So simple trauma, they've come in, they've got a big black eye, but there's actually no damage to the globe. There's no evidence of high femur. Ice packs, analgesia. High femurs, you would sit them upright. We don't want them laying down. Bed rest and maybe a pad. They usually settle, but I still would send that one off to ophthalmology, because they could have further damage that we're just not able to pick up. The retrobulbar hemorrhage, that's one where you could lose your vision, where you're going to lower the intraocular pressure with Diamox or whatever you use, and that's urgent ophthalmology review. Fractures, CT scan, because particularly if it's the inferior orbit, they can often fracture into their sinuses. You can get bleeding, you can get air, analgesia, ice. They shouldn't blow their nose because if they put pressure in their sinuses and there's a fracture, it's just not going to be good.
They get bubbles. Some people will say, I'm getting bubbles in my eye, and you know that they've got a blowout fracture.
Yeah, because the air has come up from the maxillary sinuses. And often they may need surgery if it's an unstable fracture or they've got a depressed fracture. Then Max Fax will want to see that. It's kind of a bit of an obvious diagnosis on this patient. Orbital foreign body. They're not all this big, okay? Some of them are a lot smaller. Don't remove the foreign body.
These ones.
Okay, if you've got a kid with a stick in their eye or a pen, or you've got something crazy like this. I've had a patient with a gidgee, the fishing gidgee in their eye. What you will do with this one is you will stabilise it. So what's really good for foreign bodies and eyes is plastic cups. So you kind of wrap a combine around the foreign body just to give it a little bit more support, and then put a plastic cup over it, tape it in place. You don't want this to move. You don't want the patient to pull it out. You don't want anybody else to pull it out. You don't want it jiggling around. You want that to go to theatre, because there may be a chance that they can save that globe. So otherwise, if you pull it out, that globe will probably deflate and they'll have to have the eye enucleated, which is not great.
Not best practice.
It's another obvious penetrating injury.
Sorry.
It's really good getting slides on eyes.
People still covering their eyes?
Lid lacerations. They're quite common as well. People get hit in the eye, they get a laceration of their lid. They may fall. My mum fell when we were in Rome and the arm of her glasses went through. She got steri strips. We're in Rome. What else are you going to do? So, yeah, all your eye assessments as well. But remembering the lid is quite complex. So, you've got a lot of muscles and everything there. And if you've got a lid laceration like this, you need to be checking the globe underneath and making sure there's not a penetrating injury, that it's gone all the way through. If it's a simple lac, if it's just involving the superficial aspect of the eyelid, they can be sutured in ED. They're quite simple to do. But if it involves the margins, if there's a fat prolapse, or they've got ptosis, which is a droopy eyelid, so obviously they've gone through the muscle. Don't fix it. Send it on. You know, plastics, ophthalmology is where these people need to be. Check their tetanus status, and obviously with your foreign bodies, big ones like that, you would do that as well. Don't shave their eyebrows. Shaved eyebrows don't grow back that well. You know, and if you've got... Yeah. They're not going to be happy. I know you can get great eyebrow tattoos now, but let's just not do that to our patients. So we've got time for the infections. Yeah, go for it. Bombing through it. So these are some different infections that you can get, and I've got some slides on them. So you can get a preseptal cellulitis or an orbital cellulitis, and I'll explain the difference. Allergies, they look like infections, but they're not. Herpes zoster, which is a very important one that you have to pick up in the eye, and blepharitis, which is your infected eyelids. So your preseptal cellulitis is not so much superficial, but it only involves the tissue at the front of the eye. So these patients will often settle with oral antibiotics. You know, you still do a full eye assessment on them, but they're usually not too unwell. Orbital cellulitis involves the anterior aspect of the eye, but it also involves the deeper structures of the eye. So we're looking at the muscle, the fat, you know, so the infection is not just at the front of the eye, it's all around the eye. These ones need to come in. They need IVABs. They're usually quite sick. Yeah. And this infection can actually spread quite easily to the brain because you're very close. Okay, so we mainly see kids with this. I got caught with a kid about a month ago that I thought was an early cellulitis. Wasn't sure if it's orbital or preseptal. Started antibiotics. They're back the next day and they actually had an abscess under their eyelid. So sometimes you get funky things, but the treatment's essentially the same. And that's just some frontal demarcation there with a preseptal cellulitis. So it looks nasty, and it's difficult, but I would be trying to look under the lid and just making sure there was no drainable abscess underneath that lid. It's an allergy. Usually, particularly hay fevers, they're not unilateral like this, but they come in, they've got the redness, they've got the conjunctival edema, but they're itchy and they've got a runny nose and they've got a history of hay fever, but they're well. So that is a common presentation, particularly springtime. Herpes zoster. So your patient's got shingles. We know they follow the dermatomes. There's a dermatome that comes through here. If they've got shingles anywhere, I would say scalp, anywhere in this area, close to the eyes, I would be checking their eyes. They can get a keratitis from this, and it's nasty. And they need really good treatment for that one. And I've got a slide with that on. It's your excuse me, put my teeth back in. Blepharitis. It's basically an inflammation. It's not always bacterial. You know, it's like a lot of the redness and the inflammation we see. It's not always bacterial. Sometimes it can be a mechanical irritation or a chemical irritation. So you've got to kind of nut it out. I wouldn't be like racing to give people with blepharitis antibiotics. They would need some other features there. But that, once again, comes down to your history and your assessment. This is one that brings people screaming in.
How many of you seen this? How many of you seen subconjunctival hemorrhage? And they're absolutely beside themselves that they're going to lose their vision.
Yeah. You know, and just, these people just need a lot of reassurance. These look horrible. they come in and they're worried about their blood pressure. Well, my blood pressure must be up because, you know, my eyes burst. But, you know, you can cough. you can sneeze, you can rub your eye, and I just say to them, it's a bruise on your eye. It just looks like this because there's no skin. You're just literally seeing the burst blood vessel. Thank you, excuse me.
But this is the one that causes all the problems with your parents. I probably see subconjunctival hemorrhage 5 to 6 times a day in the ED, and they're always kids.
And they're always well. So parents need lots of reassurance. So if you don't like ookie slides, cover your eyes. So this is a globe rupture. And so there's a big laceration, as you can see, through the sclera. Just through there. And they've also, that's the lens.
It's popped out.
So they've expelled the lens. Had a patient sent from a GP. And this is common in the elderly. Falling out of bed, and she'd hit her eye on the corner of the bedside table. Massive black eye, and the GP's gone, oh, I don't know, go to ED. Hadn't opened her eye. When I got her at triage, I pried the eye open because I needed to see what was going on. And the globe was just a deflated balloon in the bottom of the orbit. You obviously can't fix that, but you need to know that's what's happened. So if you do get somebody with an eye injury, their eyes swollen shut, try your best. You've got to kind of be a bit tenacious and, firm with it, but try your best to have a look at the globe within, because there can be some nasty injuries. You don't want to wait for the swelling and the bruising to go down before you see that. This is another one with globe rupture, so you can see the laceration through the conjunctiva there, and then the expulsion of the tissue. On a slit lamp, probably most of you that use the slit lamp would be aware that when you examine these on a slit lamp, that you get what's called a Siddell sign. So the fluorescein will look like a little teardrop, or it will look like a waterfall. And there's actually movement. If the vitreous humour is still slightly extruding, you'll get some movement. We're lucky. We've got a slit lamp that's got a big screen on it, and we can video it and send it off to ophthalmology, and they can see that it's an actual rupture with this extrusion of the vitreous humour.
Sometimes the ophthalmologist will actually do real time, and they can see exactly what you're seeing in real time with this particular slit lamp.
Yeah, we're very lucky.
Very lucky.
It's not clicking. It doesn't want to click. Sorry, my
Doesn't seem to want to do IT issues.
I need to go onto that slide.
Okay.
Oh, thank you. I'm not good at IT. Okay, so the management of your globe ruptures, and some will be really obvious, some won't. Stop your examination. You don't want to be messing around with this eye anymore. Put an eye shield on. We have plastic shields in ED. If you don't have a formal plastic eye shield, use a plastic cup again. Tape it in place. Lie the patient flat. We don't want them up in gravity, pulling all the contents of their globe out. Keep them nil by mouth, because they're obviously going to need some sort of intervention. Give them an antiemetic. Even if they're not nauseous, give it to them. You don't want them to vomit, because that's just going to increase the intraocular pressure. It's going to extrude more of the globe contents out. Don't put any drops in their eye. IV antibiotics. This is an injury that has huge potential for infection. Update their tetanus if they need it, and immediate referral. You're not going to be playing with these ones at all. So, foreign bodies. This is a hammering injury. Once again, back to your history. What were you doing? This is a CT, and if you look, oh, come on, IT issues.
Can you see the white light?
On the left globe
Red,
there,
opaque white, that's the foreign body.
behind the eye.
It's got all the way behind.
Yeah. So had a patient in the waiting. I was going home, but I like to front load the waiting room before I go home. Go out there, see if there's anybody that needs X-rays, analgesia. I do a quick round. This lady has been sewing, and her sewing needle broke, and she felt a pain in her eye, but couldn't see anything. I've had a quick look at her eye. There's nothing. There's no blood. There's no obvious. Eye looks fine. Eye movements, a little bit painful, but nothing. So I ordered a CT for her before I went home. And the needle had broken off and it shot up and it was lodged in her muscle, right up in the lateral aspect. Had to be removed surgically. Easy to miss. The other one, people falling over. I say my mum fell over, her glasses broke, and the arm. If the glasses shatter, they could have little bits of glass in their eye or under their eyelid. So you have to consider that as well. So another one, this is an intraocular foreign body. So it could have been somebody working with metal, hammering, and it's actually not gone into the muscle, it's gone into the globe itself. They probably would have had a little bit of uptake of fluorescein on examination, but the story would have been enough because they wouldn't have been that symptomatic with this. It's within the actual vitreous tumour itself, but that needs to be removed. These are the common ones, your subtarsal foreign bodies. So these are the ones every single eye you examine, flip the lid, because there's all sorts of stuff under there. And this would have been giving the patient a lovely corneal abrasion. Every time they blinked, they would have been scraping. It's an allergic conjunctivitis. There's no pus. You've just got, that edema there. You've got the stippling. This is the upper lid, by the way, once you've turned that. You can see that quite easily, people with conjunctivitis. And this is bacterial conjunctivitis. It can look really, really nasty. They get a massive chemosis with it. They're so swollen. They've usually got some kind of pustular discharge in the eye. Most conjunctivitises that I see, I do prescribe Clausic for because it's not always easy to differentiate, is it viral, is it bacterial? But I say if it's not improving within 3 days, stop the Clausic because the Clausic will irritate. It's viral. And in all honesty, 80% of them are viral and they're really contagious. And you just scrub your hands to death afterwards in the machine because they're just so contagious. This one isn't an eye, but this is someone who's got a viral conjunctivitis and they've just got a little preauricular node there that's quite visible. Gonorrhea in a newborn. Mother's obviously gonorrhea, vaginal delivery. That can affect the baby's vision quite significantly. You would hope they've got screening, but obviously if you're remote, Cherie's been remote, so...
So often you will see these babies, they've delivered in the bush, they're a BBA. The mothers don't stay in hospital, like they'll stay 4 or 6 hours, not even register the birth sometimes, and then all of a sudden, 4 days later, the visiting midwife does their first home visit, and this is what we see. Mum's got no antenatal history whatsoever. No visits, no, swabs, no bloods, and yeah, we see this.
Yeah, so just something to be mindful if you're out wherever and your babies present like this, test them for gonorrhea. Corneal abrasions, they usually present, often find people have had a foreign body, they've rubbed, they've abraded. They're very simple though, they're usually not too complex. These are easy to pick up. Even if you don't have a slit lamp, you can pop some fluorescein, see it with the ophthalmoscope.
Under the blue light, it'll show.
Yeah. These are the ones where I give Clausic as a prophylaxis because it's still a break in your external integrity. and then the lubricating drops as well. That will settle down. If it's a massive, deep, like you need to slit lamp them to see how deep they are, but if it's really big, if it's really deep, I will, and it's over the visual axis, I will bring them back a couple of days down the track. I want to see how this is settling. I want to make sure there's no infection, and I also want to make sure there's no opacity forming in the cornea. These are a dime a dozen. We get dozens of these. Corneal foreign bodies. This is somebody's had metal in their eye. The eye is really, moist and warm. Any metal, it doesn't take long to form rust. You think that metal goes in, and sometimes it can go in quite deep. They're grinding and it's hot, so it sticks to the eye. So even just after a few hours, they can develop some quite deep rust. Often they don't come in that day because they don't feel it. They go home, but they wake up the next morning, it's sore. They stick some cream in from the last time they had it in their eye, which they shouldn't, but they do. And then they wait a day or two, and then they come in, and they've got a really deep rust ring. And this looks like it's got a really deep rust ring. So you have to remove that. So this would be visible off a slit lamp. So you essentially can get a needle and use the bevel of the needle like a scoop, and you scoop it out. Got to have a steady hand, but yeah. Sometimes those fragments are right in the middle of the visual axis. You've got to be really wary taking those out. The cornea is at its thinnest in the middle, and there is a real risk of you puncturing it. So you've got to be very confident that you can get that out without going too deep. And often what I'll do is I'll partially take it out, give them some Clawsig. The Clawsig will soften the cornea, and it will actually help that come to the surface. So it makes it easier to get out on their next visit, which is minimum 2 days later. You don't want them back any sooner than that. And I've had patients, I've brought them back, and the minute you put the tetracaine in, it floats off. So you don't even have to dig for it. So yeah, really common presentation. How many a day would we see? Too many. Another, that's a corneal laceration. So we can see on there that the pupil's not quite round. So that would go up to ophthalmology. Bacterial corneal ulcer. Corneal ulcers, it's not the bright white, it's the dull white there, okay? And they will often look, you can see them even without being on the slit lamp, just with your torch. You can see those opacities there. They need to go off to ophthalmology. This is a fungal corneal ulcer. So if I have a patient with a corneal ulcer, particularly if they're opaque, I swab the eye. So you just do some viral swabs, some bacterial swabs, send them off. It helps guide the treatment. By the time they've seen ophthalmology, and they're a day or so down the track, we've got a better idea of what's going on. Bit like swabbing your wounds, making sure that you've got the right antibiotic. Hopopion, has anybody seen one of these? I haven't seen many, maybe one or two. So this is pus in the anterior chamber. So you can get this with your uveitis. If you've got an uveitis, if you look on a slit lamp, there'll also be, it's like stardust in the anterior. It's like little debris. But this is pus just gathering. You do not drain that, okay? Because it's not always bacterial. This is just a collection of white cells. So by draining it, you're opening up to the possibility of it becoming bacterial. So you don't want to do that. So your dendritic ulcers, these are from your herpes infections around the face. And they're really classic when you look at them with the fluorescein. They look like little octopus tendrils, so you really can't miss them. And I actually love getting these in ED because then I get the students in and the junior doctors, and I'm like, this is what a dendritic ulcer looks like. And, they've got to go to ophthalmology. And So yeah, they're a classic. Oh, be fine. Ooh. Iritis, which is another infection in the eye. They come in, they've got a deep, boring ache. They've got photophobia. They've got limbal redness. So the limbus is the ring on the cornea, on the iris. So you'll have what we call limbal flush. So there'll be a lot of redness there. If it's a severe iritis, they will have a hypopion, which we just saw, which is the gathering of pus. Sometimes it can be part of an autoimmune disorder as well, so that, once again, back to your history. So treatment for this, topical steroids and referral. And that's your limbal flush. You can just see it there, just all along the edge of the iris there. Very similar in presentation to an acute glaucoma though, and this is where you need to be able to do your pressures to differentiate. Glaucoma, deep aching pain, nausea and vomiting sometimes, red eye, blurred vision. The cornea can be hazy, and I'll show you a slide with that. The pupils fixed and dilated because the pressure's so much in the eye that the pupil can't move, and they have a raised intraocular pressure.
A lot of people think that glaucoma affects the 65 and over, but acute angle glaucoma you can see in anyone, and especially our Indigenous populations.
Yeah, so this is what it will look like. So you've got that fixed pupil, you've got kind of a halo effect on the edge of your iris. IV Diamox, again, or whatever you use to reduce intraocular pressure. Oral glycerol, pilocarpine drops. An antiemetic, once again, they're nauseous anyway, so, but you don't want them vomiting. When you vomit, you raise your intraocular pressure. And analgesia, and they need immediate referral. So we're nearly there. I've got a couple more slides. This is looking at the fundus of the eye. This is not my specialty. I very rarely look at funduses. I'm an eye injury person, but it's just handy to know. So those of you that work in ED, there is a condition called central retinal artery occlusion. Whether you get a sudden painless loss of vision, it's boom, no pain, nothing. That's an ocular emergency. They need a category 2, they need to be seen straight away and transferred. And you can, I don't have my little clicker, but you can see that just the formation of the vessels on the back of the retina there are not all complete. You know, there's some very visible ones and there's some that aren't visible. Vitreous hemorrhage, so you can bleed into your vitreous humour at the back of your eye. This is, honestly, this is why I don't see these patients. It's hard to pick up. I've only ever had one, and that was picked up by doing an ultrasound of the eye. So we're getting into too complex. I just no, go to ophthalmology, they'll sort you out. And your retinal detachments, they're common, you know, particularly in your diabetics. They go straight off to ophthalmology as well. And they've got some really good treatments for them now. They laser them and, yeah. This slide was at the beginning before. So this was the one about the child abuse. So inconsistent stories, so as I said, always keep it in mind. Blunt trauma, bilateral fractures, failure to thrive, because they're not going to be just abused in one area, it's going to be in all areas. Any retinal hemorrhage in a baby, less than 1 month, but that is usually found post-mortem because that's your shaking babies. Yeah. These are some references, and then Cherie's going to show you an app which we have on our phones. It's free. It's called Emergencies.
Anywhere in the world, and you don't need a slit lamp, and you don't Sorry, should have organised this a little bit. Yeah, so it's just a big red eye on the app, and you download it. It's called Emergencies. It was developed in one of the reference books, that your reference slide.
Yeah.
So, Handbook of Emergencies. If anyone's got that, and a lot of EDs have this Handbook of Emergencies. They've condensed it and made it into an app, so it's mobile and it's portable. It's free. But yeah, really good reference tool. Helps you out with all sorts of things. It's got lots of pictures. A lot of the pictures that we showed today, they're in that app.
Does anybody have any questions about anything?
Yes.
Initial examination, do we differentiate between the retrobulbar hemorrhage and the high femur? Because to me, the photos looked similar. So if we go to someone who looks like they've got a high femur, we treat it as potentially a retrobulbar hemorrhage and take them into hospital. Okay, thank you.
Anyone else? Yep. Here you go.
Hi, sorry, we're in Peterburg, so it's really sort of challenging for us. I just wanted to know if there's any techniques that you've got with chemical irrigation, because we do see a fair few. And basically, like, you know, we'll benzo our kid up and give him some fentanyl as well, but that's just going to be a bit amnesic. But yeah, basically we're waterboarding them more than anything else.
Often get your mums on board, and I use an IV stand of Hartmann's and just an IV gravity fed. Get them over a sink or even in the shower or the bath, and blow bubbles. You know, have bubbles, and they often compliant with bubbles, stickers. Throw anything at them, water toys, just to get that irrigation in. And it's essentially distracting them enough so that they're going to tolerate it. Anyone else? Yep. Go for it.
Just a question regarding Hartmann's irrigation that you mentioned earlier. Our ophthalmology department is still very much using normal saline, especially when using irrigation with a Morgan lens. Is Hartmann's being more rolled out as an option or a preferential irrigation method? Because I'm just curious to know how we can go back to our ophthalmology guys when we've got eye injuries in the ED and we're doing irrigation with a Morgan lens. They're saying normal saline, but if there's a argument that we can make for Hartmann's, how we can...
Hartmann's is just recommended by the manufacturer of Morgan lens, and they've got a lot of stuff online, and they've got a lot of studies there that actually show that it is more compatible. It's tolerated better by the patient because the tonicity is more in line with the eye, and it's been shown to restore the pH back to normal faster. But you're not wrong using normal saline. You know what I mean? Normal saline still works. And I think it comes back a lot to what Anand was talking about yesterday, where we've got our bias towards things. And it's like, I've always used this. Like, when I'm at work, if we're setting up, I always set up with Hartmann's. But ultimately, at the end of the day, normal saline's okay. It's just a little less tolerated. But then you've got your local that you can use, so it's not wrong, but it would be ideal if you could get the papers on it, because there are a few, because I had to produce some at work because I had this, I want to use Hartmann's, that the evidence is there, so it might be good just to gather that evidence and just give it to them. In all honesty, I don't ever do any of that myself personally. So I would be guided by what your guidelines are where you were. Like everything that we looked at was saying IV Diamox, but I think it's anything that you can do to reduce that intraocular pressure. So you guys have telehealth, don't you? You don't have ETS?
We're virtual.
Well, yeah. Look, just anything you've got on hand that will work. Do you have pilocarpine drops or anything like that? That may help as well. If you've got oral Diamox, then yeah, it's just going to take just a little bit longer to work. But then you've got time because you've got to get them back to the mainland. So yeah, I would just do whatever you can do.
The other question was diphoterane.
Sorry?
Have you ever used diphoterane?
No.
I've never used it.
Never heard of it. Ah, okay. Is that the one for the hydrofluoric acid? Okay, no, we don't have that either. I've used the calcium gluconate gel because we used to be down at Kwinana near the Strip, but yeah. Each place will have its own things. That's the thing. It's kind of a generic, use whatever you've got available to you.
All right, let's hear it for Cherie and Jackie. Thank you both for that very informative talk, and I hope you guys didn't squirm as much as Dylan and I did when seeing some of those pictures. So, what's the plan now? The bus is already out there for the waterfall tour, and I think maybe the whitewater rafting one. So for those people heading that way, hope you have a great day. Everyone else, please feel free to hang around for Scott and Alex's talk, which is all about planning for your future. So that's the optional session there that we have. If you're unable to make that one, or you weren't able to make yesterday's session, they are all available on our streaming links. That's all through the online portal. Enjoy the day, remember your photos, and we'll see you all here tomorrow. Cheers, guys.
I'm just going to have a nap in the car.
The response is going to be no.
Alrighty, good morning everyone. Thanks for hanging around. Like kind of we said yesterday, We've got some slides to go through, but can take this in any direction that you guys want, and skip over stuff if it's not relevant, or delve into more detail if the questions and direction you want to take it warrants that. My name's Scott, and this is Alex, and we're two financial planners at Everest Wealth, based out of WA, but we've got a national presence, advisors all across the country. Just before we get started, just a general disclaimer warning that what we talk about today is general in nature. It doesn't take into account anyone's personal or individual circumstances. So let's get into it.
Cool. All right. So what we will be covering today, so a little bit more of an intermediate or advanced session. However, as Scott mentioned before, we can sort of go anywhere with this. Just ask your questions as we go. So we'll be covering self-managed super funds first. Then we'll be looking at how you can use what's called equity in an existing property to expand your property portfolio. As an example there as well, we'll be looking at something called debt recycling, which you may have heard of before. Why it's really important to continue to put money into your super and the advantages of that. And then finally, we'll touch on a bit around retirement planning, including the Centrelink pension and a few things like that as well.
Does anyone in this room have a self-managed super fund? Just one? Cool. Has anyone else heard of a self-managed super fund? Most people in the room? Yeah. So I guess what we just wanted to talk about is when you may have one, what's the difference of a self-managed super fund to kind of an industry fund or a retail fund? So I guess starting off with what is a self-managed super fund, it is no different in terms of the legislation, the tax rate to a normal super fund that the majority in this room would have, whether it's an industry fund or a retail super fund. It allows you, though, to have more control and more flexibility. And the main point on that is the investment choice. So it allows you to buy assets that your normal super fund cannot. And in the main, that's residential and or commercial property is the main reason why people will set up a self-managed super fund.
Yep, next one. Cool. All right. So some of the criteria to consider, in our opinion, of whether a self-managed super fund is relevant to yourself. So generally, you need to have around about $500,000 in that super fund to begin with. The main reason sort of around this is typically the cost involved of having a self-managed super fund. So there will be additional costs as opposed to a more normal super fund, because you need to have the audit, for example, done by an accountant. It needs to have its own tax return done, things like that, which typically cost a lot more than what you're charged in, say, a standard industry fund as an example. You need to have a good understanding of the compliance around what you need to do with the fund, because you are now solely in charge of it, and you are the trustee often as well, so there's a lot more responsibility. Obviously we're a bit biased because we're financial advisors, but we do recommend that you have a financial advisor or an accountant that helps you manage this as well, to ensure that you stay within the rules and you don't accidentally make any mistakes and go into breach in any sort of way. And then finally, it's just making sure that you actually need it for a specific reason, i.e. you want to invest in something which you can't get through a standard super fund.
Cool. And I guess when we're talking about the 500 grand or so kind of balance to commence one, that's combined. So with a self-managed super fund, you can have up to 6 members. Generally speaking, that's family members. So a couple will normally start one, or maybe siblings will start one and pool their money together. So it's kind of the power of having more money together now. And that's what we talk about when having 500 grand. It's kind of combined, not individual. Pros and cons of a self-managed super fund. So starting off with the pros, like I've already indicated, the control and flexibility is just a lot more than your generic super fund. The investment choice, so a wider range of assets. So expanding on the property conversation, you can buy antiques, collectibles, cars, as an example, inside your self-managed super fund that are more antiques as well. Artwork is a popular one as well, gold bullions and stuff like that too, okay? And family involvement. So this is quite often that, family will get together and pool their money together and commence a self-managed super fund and work together for their retirement. And even though there's potentially maybe a mum and dad and their kids are getting involved in a self-managed super fund, different stages of their life, you can have kind of different assets that suit more of a retirement kind of outlook, and also more of an accumulation or growth for those younger kind of people within or members within the self-managed super fund.
Okay, so that was some of the advantages. Now for some of the disadvantages. So starting with, I guess, more time and effort. So because you are now running this yourself, it does require, basically more time, more care, more responsibility, as opposed to, again, having a more standard super fund. Secondly, as I sort of already touched on, the legal and compliance side of things. So there are a lot of rules and laws when it comes to superannuation. So you do want to make sure that you are being very, very careful. An example of something that we see quite a bit when clients come and see us and they have an existing self-managed super fund is they haven't, they're not necessarily completely aware of their own investment strategy. So for example, their investment strategy may say that they can only have up to 25%, say in the Australian share market, and then when we look at their portfolio, they might have 50% because they've bought some stocks themselves on the ASX or something like that. They're actually then in breach of their own investment strategy, as an example. So really making sure you know what you're doing when it comes to those sorts of things. And then, lastly, cost effectiveness, which I sort of touched on before as well. It is typically a lot more expensive to have your own self-managed super fund as opposed to, say, an industry fund or something like that in terms of the fees. So it is making sure that you have enough money to effectively justify those costs as well.
Easy, but one of the main reasons that people commence a self-managed super fund is the power of borrowing money. So it's a great way to accelerate your wealth, whether it's personally or through your super. If we look at kind of most people in the room no doubt own a property, so you're borrowing money from the bank, and now you have a larger value asset that appreciates a lot quicker because it's a larger value asset than, say, putting $500 away into the share market or into the bank each month. Same goes for self-managed super fund. It's a bit harder to lend money than in your personal name, but it's still possible. There's three ways you can lend money. So you can lend from the bank for a commercial or residential kind of purpose, or you can self-lend. So if you're in a great position where you've got a lot of cash, maybe you're debt-free as well, you can actually lend that cash to your super fund. You can then have a deemed interest rate, which at the moment's 5.35%. So your self-managed super fund then pays 5.35% interest back to you, your personal bank account, and then your super fund's able to use that money to purchase a property or whatever it is that you want to purchase with that lent money. So then it's meaning that you're getting more money into super, and then you effectively become the bank, so you're not paying the bank any interest in that case. So obviously, to be able to do that, you need a substantial amount of money, but that's one thing that people do there. But yeah, there are a few banks that offer lending to self-managed super funds. Things to be aware of, though, the interest rate generally is higher. So we've seen it as high as kind of 10% for some clients, which is obviously a lot higher than 6 or so percent, which is what personally we can lend at the moment. But this is one of the key benefits of having a self-managed super fund and getting into the property market within your super directly.
Is there any questions on self-managed super funds? I know we went through that relatively quickly. Yep.
Yeah, for sure. So if you've got the cash, so let's say your self-managed super fund owes the bank $300,000, and if you've got $300,000 in your personal name, then you can kind of borrow that into your super, pay off the bank loan, and now your super fund owes you personally. So now you're not paying anyone externally the 5.35% or 10% interest. You're paying yourself. Sorry. Yeah. So you set up an agreement between yourself and your self-managed super fund, and literally transfer money from your bank account in your self-managed super fund to your personal bank account. Yeah, the interest each month. But yeah, it can definitely be kind of changed if that's how you've got it set up at the moment. Yep. Yeah, sorry. Yeah, so you can use it for residential, but it does need to be an investment property. You can't have a self-managed super fund and live in that property. It needs to be what's called arm's length. So yeah, that's something probably I glazed over. It does need to be an investment property. Quite often, business owners will buy their own commercial property within their self-managed super fund. So that's probably the only time where it's a bit closer to home, where you're working in the office building or warehouse that your business owns. Yep.
Yes, but you would need to then pay rent to the self-managed super fund, and you need to also pay it at market rates as well. Okay, so likewise, if you bought a residential investment property in your self-managed super fund, and then you just let your kid live in there for $100 a week or something like that, that is technically in breach, because that wouldn't be at market rates either. So it all comes back to what they call the sole purpose test, which is surrounding legislation of superannuation, which is effectively, it's the sole purpose of superannuation is for your retirement. Okay.
Yeah, mate, at the back. Yeah, it's still segregated. I think I get what you're getting at there. It's still segregated. So if you've, say, got $100,000 in super and you add it into the mix, they can't access any of your $100,000, and over time that will grow. That's kept completely segregated to you. If you own a property, like if you pull all your money together and you only own one property within the self-managed super fund, the income that receives, say, from rent, it has to be split based on your percentage holding of the super fund. So if your 100 grand that you put in is 20% of the overall self-managed super fund, then 20% has to remain in the fund under your name, or your bucket, and the 80% can be gone off to your parents. So probably in that situation, it wouldn't make sense to do, because there's no benefit to your parents from you pulling the money in at that late stage.
Yeah, so you have your own separate member balances within the self-managed super fund based on effectively, how much you have. Yeah, so theirs would still be asset tested on their own separate member balances. So your balance wouldn't affect theirs in that example. So that's where you often will see self-managed super funds, say, in families, because you can have up to 6 different members. Okay, so maybe in your hypothetical example, you really wanted to invest in residential property or something like that, and you've only got 100 grand, which wouldn't be enough to potentially secure any lending or be able to purchase anything, but your parents have got 2 million or something like that, so you pull it all together, purchase something, but again, like as Scott said before, you would only be getting your share of your balance as the return or the income.
Cool. Any others before we move on? All good? Cool.
Okay, one more click. So we'll now touch on using equity in a property. So yesterday, there's a few familiar faces as well, which is great. Thanks for coming again. A lot of you, by the looks of a show of hands, had owned a property or currently own a property. So this is what we're talking about here when it comes to equity. So equity is effectively money within a property, okay, that you can then potentially use to then pull out and potentially purchase another property. So one of the real powers of the property asset class is this ability to leverage, and the fact that the banks are effectively quite comfortable with it, as opposed to, say, shares as an example. They're not often quite as comfortable leveraging against shares, even though historically they've returned very similar amounts. So that's what we're talking about there. So Scott will go through a worked example in just a sec in terms of how you calculate how much potential usable equity you may have in a property. And then how much value or equity do you need before you can use it? So you generally have to have, in terms of an LVR, that needs to sit below 80%. So typically we were talking about yesterday that you put your 20% down as a deposit on a property when you borrow to avoid lender's mortgage insurance. So you need to have an LVR below that, okay, before you sort of start coming into the realm of usable equity.
Yeah, so a quick example to kind of highlight that. So the bank will value your property, and let's say the bank values your property at $800,000 and your loan's $560,000. Your loan to value ratio at the moment is 70%, so you've got 30% equity in the property. So effectively we can take out 10% as usable equity, so we could pull out $80,000. The downside to that is that will increase our loan from $560,000 to $640,000 and thus increasing our repayments. But it therefore means that we've now got $80,000 to put down on another asset, whether that's shares or another property, to continue growing our portfolio. And that's how potentially you've heard of people that have 10, 15 investment properties. This is kind of what they do. They just pull out equity and go again and keep doing it and really use the bank's money to leverage and get ahead, which historically speaking, with the interest rates being lower than what they are today, has been a really good strategy to do.
Cool. So a little just return chart here on property and some things to then sort of consider on that as well. So liquidity. Okay, so typically housing isn't a liquid asset, and as in it takes a long time to sell sometimes. There's high transaction costs, those sorts of things. But pulling out equity actually does the opposite. It allows a lot of liquidity because effectively you're not actually having to produce any cash. In that example before, you would simply just use that extra value you have in that home as that deposit for the next one. So you don't actually have to front up any of your own cash. Interest rates, so as Scott mentioned as well, if you are then pulling that equity out, you are then obviously you're borrowing it effectively, albeit that if it is for investment purposes, the interest will be tax deductible, which obviously helps a little bit, but making sure you consider the interest rates that you're borrowing out in your own cash flow. Which is also into the next point as well. So yeah, that cash flow effect of equity in that, yeah, your repayments will now go up as a result. And then looking at this chart, however, it's the growth of property. So, you know, in Australia particularly, but also around the world, it has been a great asset long term. I'm not sure how easily you guys can see that from the back, but this is a 30-year period. Got houses and units as an example here as well. And housing, this is in Australia up until July 2022, so it would have gone up even more since then. Has done 453% as a sort of gross return there. And units have returned around 300%, so they've still been very positive as well.
Whereas kind of in that same time frame, if you just stuck money in the bank, it's returned on average kind of 4% a year, which is obviously a lot less than what the property market has done. Any questions on using equity or anything around that? All good? Has anyone heard of debt recycling? No? Okay, so this is a relatively higher risk strategy that you can deploy. But it's a way of turning your principal place of residence, so where you live, mortgage, into a tax-deductible home loan, okay? So why is a tax-deductible home loan or an investment loan beneficial? Because you can claim the interest that you pay to the bank on your tax, okay? So let's have an example where you've got a $500,000 investment home loan and you're paying 6% interest rate, you're paying the bank $30,000 a year in interest. You can then claim that $30,000 in your tax as a massive tax deduction and therefore get a lot of tax back that you pay throughout the year in your employment income. So debt recycling effectively recycles your home loan into an investment loan over time. So how do you do it? So it's in the wrong order, but step one, we need to pay down quicker our home loan. And by paying it down quicker, they'll become more available in redraw, okay? So you'll have a higher amount in redraw that you can redraw back. So when it gets to a point where it's about $50,000 or higher in redraw, you apply to the bank to redraw that money. We then want it as a separate loan. So in that example of $50,000, we now have a separate investment loan. And then we invest that $50,000 into a term deposit, into the share market. It just needs to be invested. And then that $50,000 becomes tax deductible. The investment that we've now invested in, whether it's a term deposit, whether it's a share or an ETF where it's now paying us kind of dividends and interest, we take that interest or dividends and put it onto our home loan. So we pay it off again quicker and quicker. The redraw builds up. A year or two later, we apply to the bank to redraw more money, maybe another $50,000. So now our investment loan is $100,000. And now that interest we pay is tax deductible. And we effectively keep doing it until our home loan, in the example I was using before, the $500,000 home loan is now a $500,000 investment loan. But at the same time, we've now got $500,000 that's been invested. And then when that occurs, we then start paying off the investment loan. So it means we'll have debt for a bit longer, but by the end of it, we'll also have a massive investment portfolio as well. And it saved us a lot of tax along the journey. Any questions with that? Yeah.
So are you asking if you can use the value of a car to secure another asset?
Yeah, so you can do that, but it's not tax deductible.
Yes, you could, yeah, but it wouldn't be tax deductible necessarily.
Yeah, you can do that. So you can redraw equity or take equity out of my home to gift it to my kids to buy their first property. What's probably more common though is just the parents to go guarantor, so there's no changeover of money. That's probably a more common way that we see to do that.
And you'd probably want to go the guarantor option anyway, because then when the kids are borrowing that, you're using their parents' house as a guarantor to then secure that next property. It actually then gets split into two loans, which the kids are then paying. Whereas the way that you're describing it, if you pulled the equity to then basically give them the cash effectively for the deposit for the next home, you're technically liable to pay that. So it'd be cleaner just using the guarantor option in that example.
Yeah, Timmy. No. So this is like, because you might already have equity in your home loan, so it's not taking that out and increasing your home loan. We don't want more debt than what you currently have with this strategy. It's just recycling it. So you kind of start from scratch today. You would pay extra onto your home loan over the course of a year or two, build up your redraw to be bigger than what it is today, and then redraw that amount back.
Yeah, so let's say your LVR is starting at 70%, okay? You pump extra cash in to then improve your LVR to say 60%. You take the 10% back, okay? So via redraw in this example, invest it into an income producing asset like shares or something like that. And that 10% now of the loan, the interest on that is now tax deductible. Okay, so what that actually then allows you to do is effectively get a discount on the interest rate, which you didn't have before because it was your principal place of residence, okay? But now because part of that is deductible, you're effectively getting a discount on that interest rate. And what this strategy is talking about here is effectively just washing the whole thing from being non-deductible to deductible, back at 70%, but now the whole thing, say, is deductible in this example, which then will just allow you to pay it down a lot faster. And at the end of that strategy, then you would have a debt-free house and you would potentially have a share portfolio as well with no debt. So it will take longer to pay down the debt, okay, as opposed to just paying it down. However, with this strategy, it's very tax effective because, like I said, you end up with a debt-free house and, say, a share portfolio of 500 grand or $1 million, depending on how much you've washed through the loan. That would be very similar to what we were talking about before. Typically debt recycling is used with shares. However, it is effectively the same thing. I guess in the example before, we were taking on additional debt with equity. Okay, so you actually, whereas this is simply just swapping the existing debt from being non-deductible to now deductible. There's no actual increase of debt in this strategy. So that's exactly right. So the high risk element part of it is just simply in the short term because of the volatility you'll typically have associated with shares. So that's the only, so it's high risk in the short term because you've obviously now got to make sure you can still cash flow it and stuff like that. But yeah, in the longer term, a lot of that risk is obviously removed in some of the charts we were obviously showing yesterday as well, that the share market has always outperformed cash over that longer term period. Yeah, exactly. Same, very popular way. So if you receive it, literally, and then the next day, hey, can I redraw this? Apply to redraw a separate loan, and this is kicked off underway. Absolutely. So if you do have a lump sum of money and the idea is to pay off your debt, that's potentially a better way to go about it. Yeah. If you have, I guess the time frame with the investment side and that, which is what we're talking about, the high risk, it all comes down to your time frame of when you want to be debt-free and how long we have to invest the money. Yeah. And if you want to grow your wealth as well. Ideally kind of 7 to 8 years and beyond, and you're never going to be able to guarantee that you're going to have a positive outcome, but it's very likely based on the last 100 years of data, kind of any kind of 8 to 10 year period, you've done better. But in the shorter term, anything under 5 years in particular, there's no guarantee. Like if we look in 2007, the global financial crisis, it took nearly 7 years for it from the peak. It dropped for 18 months, and then it took almost 6 to 7 years to get back, and it was kind of 2014 before it was kind of back level with 2007 kind of heights. Yeah. Absolutely, yeah. So if you've got other assets, where it may be cash or a super or whatnot that you can utilise first and let this run through and recover, then that would be the best way to go about it. Yeah. Yeah, but you wouldn't do this strategy if you were in complete retirement and you weren't actually earning any income in your own name. Yeah, because the interest is tax deductible. That's sort of the advantage of it. Any other questions, guys, before we move on off this? So 2 different strategies that we've talked about. So using equity to build your property portfolio is one. Debt recycling, completely separate strategy. Which is more about keeping the same level of debt, but just changing it into a tax-effective kind of debt. Yeah, and I'll just finish finally on that one as well. Where it makes most practical sense normally is in you're in your principal place of residence. Maybe it's your second or third home, and it's kind of like your forever home per se, or some place that you're going to sort of stay for around at least sort of 10 years. That's when then it potentially makes sense to enter into something like that. Because if it's any sort of shorter than that, just the administration and the advantage is not going to be that great. You get the real advantage sort of 10 years plus from doing it. Well, they're 2 completely different things. So the advantage of doing that, is potentially if you're younger and then you want to access or have passive income prior to say 60 or 65, then that strategy would make more sense. But yes, if you are older, or getting close to 60 or being able to access your super and you have another lump sum of money, then potentially it may make more sense to put it into super. Yeah, so it's always, you've always got to consider your own personal circumstances and all of these things in terms of, where you're at, in terms of your age, lifestyle, what you're looking to do, your tax rate, all those sorts of things. Okay, those were some good questions. Thank you for that, guys. Okay, so now we'll talk a little bit more about super. So effectively, why would you put more money into super? It's the best tax structure you have available to yourselves, so it only pays tax at 15%. We talked a little bit about this yesterday as well, but that's going to be a lot lower than your typical marginal rate of tax, so you're going to save tax ultimately by putting it in there, first and foremost. Money for retirement, so in retirement, obviously you want to be able to fund your lifestyle and ensure that you've got money to do all the things that you want to do as well. And also currently right now, when a super fund gets turned into what they call pension phase, it then effectively pays 0% tax from that point in time as well. So very, very tax effective at that point in time because you're paying nothing. So ultimately, potentially having as much money in super as possible heading into retirement generally makes some sense.
Yeah, so I guess if we kind of run some quick mental math on that, if you've got, say, $500,000 in super and that generates, say, a 10% return, you've made $50,000 that year in your super fund. In your super fund, you have to pay 15% tax, so you would end up paying $7,500 tax to the ATO in that example. When you reach over the age of 60 and fully retire, or over the age of 65 if you're still working, your super turns into a pension, not to be confused with the government age pension, but your super fund changes its name, stays in the same spot. But now that 50 grand, if we earn 50 grand, is tax free, so I get to keep all of that 50 grand. So that's why super is so attractive. And when you reach the age of being able to access it, the biggest mistake people can make is withdrawing all of it to their bank account. Because when they make money from the bank account interest on that money that they've withdrawn, they'll still pay tax on it because you're still liable for your marginal tax rate depending on your situation. If you had 500 grand in your personal name and you made $50,000, if you're earning kind of over 45 grand, you're going to be paying 34, 39, 47% tax on that. So potentially upwards of 25 grand tax on that. So that's where super is the best tax vehicle for us in Australia. Okay.
So it's easy then to sort of think about it in terms of maybe what you earn now. So say if you're earning $120,000 as an annual salary, you might lose sort of 30 grand in tax, so you end up with roughly sort of $90,000 in your pocket after the taxman's had his share. So if you think about that, if you got that completely tax-free, okay, that $90,000, it's like it's effectively the equivalent of, say, only working 3 out of 5 days a week or 4 out of 5 days a week and still earning the exact same amount of money. That's often an easier way, I think, to sort of relate to it as well, the power of effectively paying no tax in that pension phase within super.
So moving on from that, there's 3 main ways that you can get money into super. Okay, so there's a concessional contributions. That means where you're claiming a tax deduction on the contributions. So the most typical way someone does this is through salary sacrifice. The other way you can do it is through a lump sum into your super and then you claim a tax deduction on that. There are caps with this, so at the moment it's $27,500 a year. That does include what your employer puts in, so that's important to note. So if you're earning 100 grand, you've already got 11 grand going in. So that comes off of that $27,500 cap as an example. So then you'd only have kind of $15,000, $16,000 left. With the concessional contributions, if your balance is under $500,000, you can make what's called catch-up contributions, which is a very viable strategy if you're looking to potentially set up a self-managed super fund and get to that higher balance so you can borrow money easier, or if you're nearing retirement and you want to put more of the money into super from the potential tax savings that we just spoke about, particularly when you get to the pension age where it's 0% tax. So what the catch-up contributions are, it allows you to go back on the last 5 years and make catch-up contributions for the gap that you haven't maxed out your cap in those 5 years. So maybe over the last 5 years, you've had kind of 10 or 15 grand in each of those years. So then you can come back and make maybe up to a 75 grand contribution into your super in one go, claim that on your tax, and effectively probably get majority of the tax back that you paid through your employer throughout the year.
Where that may make sense as well, if I can quickly interject, is if you are selling an asset potentially in that year as well. So potentially you sell an investment property, you make a very large capital gain on that. You can potentially use some of these catch-up contributions to then give yourself a better tax deduction to minimise then that gain on that one-off sale during that financial year as well.
Yeah, with the downside being that it's now in super, so it's locked up. So depending on your life stage and where you're at, that may or may not be a viable solution. So that's the concessional. Non-concessional is where you can put larger amounts of money into super, but it's after-tax money. Okay, so you can't claim it on tax, but you can put up to $110,000 in each year. You can do that as a bring forward as well, so you can do 3 years in one go and do $330,000 and then not do anything for the preceding 2 years. Why would you do this? Again, if you're nearing on retirement, getting more of your assets into super makes sense because it's only taxed at 15% compared to your marginal tax rate, and then 0% when you fully retire. So the money that your super fund generates, you get to keep it all, whereas if you're holding investment properties and large amounts of cash or shares outside of super, you're still potentially paying tax if that's generating over $18,000 a year when you're fully retired. Okay. The other one, spouse contributions, are very popular when people are on maternity leave is generally where we see this. So it's a way that you can continue to boost the non-working spouse's super during that time. So if the spouse during the financial year is earning less than $37,000, you can make a $3,000 contribution to their super, and then the working spouse will get $540 back in their tax return. So effectively, you're giving up $2,500 to have $3,000 go into super. So it's not a huge saving, but it means that there is still a saving and an incentive to kind of keep the non-working spouse's super growing during that time. Any questions on the contribution types or anything? So it's not taxed, so that $330 will land in your super and get invested, and no tax goes to the ATO. But when that makes money, 15% of the profits will go to the ATO, which is why we're talking about that. That 15% is better than your marginal tax rate at 34, 39, 47%, yeah.
Yeah, so no contributions tax, but it still pays tax on what it earns, but at 15%. Cool, and then I'll just add to that as well when we're talking about the spouse contributions before. Another thing you can do is called super splitting. So this doesn't add any tax advantages necessarily. However, if you've got a situation where you've got a primary income earner and a primary carer per se, because they've got a few kids and stuff like that, so they're out of the workforce for a period of time, you can actually split up to 85% of your employer contributions to that spouse as well. Okay, so why would you want to do that? Predominantly because, if Scott just clicks through a little bit more, there's now a balance cap of about 1.9 mil per person, okay, in terms of how much you can have in pension phase at that 0% tax rate, because above that you'll go back to paying 15%. So what I'm getting at here is it makes sense if you have a couple that they've both got 1.9 mil in super, because then they would earn 0% across both of those, as opposed to one person having 4 million and one person having 0. Okay, so that's worthwhile sort of considering as part of your planning. If you are going to have a situation where you've got quite large imbalances between a couple superannuation balances, you can split up to 85% of the employer contributions to the spouse. Cool, all right, so this just quickly summarises what we were talking about before. So accumulation versus pension phase. So accumulation is before you retire, and then once you hit that retirement or meet those conditions, you effectively go into pension phase, at which point, as we sort of said, 0% tax at that point in time for balances below 1.9 mil currently.
Yeah, so there's two pensions. So the government pension, if you're eligible, is from age 67 at the moment. But with your super, you can access your super or turn it into a pension or a transition to retirement pension from age 60, generally speaking. And then if you fully retire from 60, you can have a tax-free pension, or if you're still working from age 65, you can have a tax-free pension. And when I say tax-free on the money it makes.
So potential access from 60, full access from 65, sort of regardless of circumstance currently.
Cool. All right, so the effect of doing some of this, particularly if you're a bit younger. So this is just an example of a 36-year-old earning 120 grand a year, and they start salary sacrificing 5% of their wage, which is $500 a month or 6 grand a year. They've got a current super balance of $112,000, which is the average for a 36-year-old at the moment in Australia. Now, in terms of and I'm sorry, this is obviously hard to see on the screen, but in terms of the effect on their take-home pay, it's about $150 a fortnight or $300 a month to put that $500 into super. And that $200 is just down to the tax savings of being able to claim that on your tax and not paying tax at your marginal tax rate on that $500. Okay, so it doesn't really affect your take-home pay too dramatically, but obviously during these times with higher interest rates and rising costs of living, this does become a bit tougher to potentially commence or continue to do if you are doing it. But the benefit longer term, if someone was to keep doing that based on a 7% kind of growth rate in the super fund per year, is close to $500,000. So if you can kind of earlier on in life, and it's never too late to start something like this, but the earlier you do start it, the longer it has to compound and make a bigger difference. In this example, this person would be giving up $150 a fortnight, but have an extra $500,000 by the time they can access their money. Okay.
Cool. Any more questions on contributing to super or anything like that before we jump into the last part, which is just around retirement planning? Cool. All right. So retirement planning. So the first thing to consider is, what does retirement look like for you? Okay, and it's never too early to sort of start thinking about this stuff in our opinion as well, because it will be very different from person to person. So we did get asked the question yesterday, how much do you need in retirement? The answer is, unfortunately, it really just depends on your own circumstance. So what you want to do in retirement. So whether you want to be taking overseas trips every year, or whether you're happy with more domestic travel, if you're going to have a caravan, if you're going to have a boat, if you're going to have a holiday house, if you're not going to have any of those things, if you want to leave a legacy to your kids, or you're not going to leave anything to your kids. So these are all just very quick examples of some things to think about which will shape your own retirement. We do have here, though, however, the ASFA every year puts out what they sort of consider a comfortable retirement. So it's a little bit hard to read on the screen here. This is assuming a homeowner. Okay, so a homeowner, they reckon for a single person about $50,000 a year is what they need to have a comfortable retirement, whereas a couple, they are saying a smidge over sort of $70,000 here. And they've got some examples here of what they consider a comfortable retirement to put it in context. So some of the things on here are being able to pay all of your bills, money for food, medical insurance, staying socially engaged, so being able to go to the movies, having subscriptions like Netflix, those sorts of things. And then from a travel perspective, it's one overseas trip every 7 years and being able to travel domestically every year. Okay, so that's what they consider comfortable. That may resonate with you, that may not. But again, you need to consider what it looks like in your own circumstances.
And with retirement, there can be plenty of different income sources, okay? So superannuation, which is a large part of what we've been talking about today, will form probably the largest part of the income source for the majority of people in this room. The age pension, so we've kind of touched on that. Now, it will probably get phased out over time because as people have been working their whole life and had kind of 9.5% or above super guaranteed contributions, which is of their wage going to super, they should be self-sufficient by the time they reach age 60, 65. So the age pension will probably be phased out, maybe not in its entirety, but it will look very different in kind of 10, 20, 30 years. So that's why it's important to kind of really make sure you are building your own retirement. Drawing down on assets outside of super, so that's probably the first thing you want to do when you do retire. If you've got assets outside of super, whether that's cash, shares, investment properties, using those assets if you can. Not saying you should just go and sell an investment property just for the sake of it, but using assets outside of super and then starting to touch your superannuation assets because it's in a better taxed environment. But that's another income source that people will have available to themselves, and downsizing is a big one as well. So there is some rules where if you do downsize your principal place of residence before retirement, you can put in the difference into your super fund as well. Okay, so that's just another way you can get more money into super, which again reiterates what we were talking about before around the tax concessions.
Cool. Yep, so pretty quick one here. So what we call income tiering. So a common question we get sort of day to day is, do I have to just take a set amount every year until I pass away or 90 or something like that? The answer is absolutely not. So you are able to take as much as you want at the start. There are minimums that you have to take, so it starts at 4% of your balance as an example. However, you would often look to probably income tier these things. So if you are retiring at 60 as an example, you're still potentially very active. There's lots of things that you want to do, say in that first decade. you are able to take a lot more money, for example, during that period, and then potentially sort of scale it down over time as well as you do get older, and say you have ticked off those milestones of Europe or the USA or or any of those sorts of things, those bucket list items, I guess.
Just quickly on the age pension. So at the moment, you have to be 67 years of age or above. You have to have under $605,000 in assets if you're a single, or $939,000 in assets if you're a couple, and this is assuming a homeowner. The home does not come into consideration with this asset kind of calculation or adding these up, but your superannuation does. Okay, so it's your superannuation, any investment properties less debt, cash in the bank and shares broadly are all added up together. If it's less than those amounts, then you're eligible for at least a part pension. Okay. There's also an income test. So if you're still earning income, whether that's from investment properties, shares, as dividends, or you're still working, if you're earning over 62 grand as a single or 92 grand as in a couple, then again, that will mean that you're not eligible to claim anything. If you're under that, then you potentially are eligible. And what the test does, so there's an income test and an asset test, it effectively takes the worst one for you. Okay, so if you're earning kind of $20,000 a year as a couple, but you've got no assets, it will treat you as the income test. Okay, so we'll always look at kind of the worst outcome for you, and that's how they'll test you.
And another quick question we often get on that as well is, if I'm not eligible at 67, does that mean I don't get it at all? And the answer is no. Okay, so that safety net is always there. So effectively, you may not be eligible at all to begin with at 67 because you have too many assets or you're earning too much income, as an example. But as those assets diminish or that income diminishes over time, you can potentially become eligible, for example, at say 74 or something like that. So we've always got that safety net in place in our current system.
Yeah. And I guess the pension at the moment is about $40,000 a year for a couple and $26,000 a year for a single. So if you do splurge early on and kind of utilise all your assets outside of your home, you just got to be aware of what the lifestyle is going to be post that. So it's not going to be the most extravagant lifestyle Alex was showing before. Kind of 70 grand is a comfortable retirement for a couple. The pension's about $40,000. So that's obviously not going to be a very comfortable lifestyle.
Cool. All right. So final slide here. So just some things to take away from today. So whether a self-managed super fund is potentially appropriate for your situation, or potentially if it will maybe become appropriate in the future. Considering using equity or debt recycling to accelerate your wealth journey or to effectively make you more money. Consider options to build your super balance for retirement. So it's never too early to sort of think about that, as Scott showed that example before of just putting a little bit extra makes a big difference at the finish line. Do you feel you're on track for your desired retirement? So again, never too early to start thinking about what you potentially may need and what you want to do, as an example. Insurance, so ensure your income is protected and your premiums are competitive in super as well. So we didn't talk too much about this today, but we did yesterday, but something just to reiterate and be mindful of. Do you have a plan in place to build wealth and create passive income as well? Because again, if you potentially want to retire early prior to say 60 or 65, you are not going to be able to access your super, so you need to ensure you have some sort of assets generating you some sort of passive income other than just your own ability to make money through your own personal exertion. And finally, ensuring that your estate planning is up to date as well in terms of a will and whatnot as well. Cool. All right. So that's it from us. So yeah. So my name was Alex. This was Scott. Both financial advisors from Everest Wealth. If you do want to have a chat to us about your own personal circumstances, we do offer a free 15-minute introductory call to have a bit of a chat to you about your own personal situation and whether we could potentially help as well. We're going to be hanging around during the week. You'll see us at the closing party or potentially at the pool or anything like that, so feel free to come and have a chat then if you want as well. And thanks very much for hanging around this morning.
Cool. Thanks, guys.
Oh yeah, sorry, yeah. If you do have any questions as well, you can ask us questions. We'll be hanging around for 5 minutes. And if you did fill out that feedback form, just leave it on your desk and we'll come grab it. Thanks.